morning, everybody. I wish everyone a very healthy and a happy 2022. Welcome to the second day of the 21st International Symposium on Diabetes. As usual, we always start on time. I would now request Anirudh from 1MD to play the Ganesh Vandana. Welcome everybody to the session. Let's all rise for the Indian national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उज्ज्वल जलधि तरंग तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you very much. Now I ask Dr. Dakshata Padhe to start the proceedings for the day with Dr. Jimit Vadgama.
Good morning, everybody, and warm welcome. So before we start today's day, a small brief update about yesterday that we had login of about 73 countries yesterday and more than 62,000 logins from start to end of the day. Today's session, we are starting with Sir Dr. Shashank Joshi. Sir needs no introduction in today's platform or any international or national platform. Accompanying Sir will be his dear student, Dr. Chandni Jain. She's a dedicated diabetologist practicing in Andheri West, and we all are trying to follow Sir's footsteps. So today's session will be, so you'll start today's session. Management of diabetic dyslipidemia in Indian patients meeting target saving lives. Over to you, Sir.
Dr. Chandni, you can introduce the speaker.
Sure.
Professor Subhash Wangno is one of the world famous endocrinologists. He was one of the first endocrinologists to start practice in New Delhi. He's originally from Srinagar, Kashmir, and subsequently he moved to New Delhi. He's trained in DM endocrinology from BHU, Banaras Hindu University, and he has been a WHO fellow also. He's the senior most endocrinologist at the Apollo Hospital, and we will now listen for his keynote address.
Respected chairpersons, now I am privileged to talk upon the management of diabetic dyslipidemia in Indian patients, meeting goals and saving lives. Well, to start with, we should know that a risk factor for diabetes in India is basically the positive family history, obesity, the hypertension, abdominal obesity, urban residence, and some the age and the male factor. Apart from that, there are some typical Indian phenotype, like the Indian patients or even the Asian Indians have higher insulin resistance. They have greater abdominal adiposity, higher waist circumference, and they have the characteristic diabetic dyslipidemia, with high triglyceride, low HDL, and the high small dense LDL particle. The Indian phenotype challenges because of the greater abdominal adiposity and the visceral fat at any given BMI, what you call the thin fat Indian phenotype. Higher waist circumference and the waist to hip ratio. The waist circumference, we call it if it is more than 90 centimeter in male and more than 80 centimeter in female, to be having the higher waist circumference. Typically, the Asian Indians have low levels of adipokine and high plasma leptin with increased concentration of triglyceride. And there's a low rate of glucose disposal, impaired insulin secretion, and the increased insulin resistance, and is coupled with the genetic factor. These are all contributing factor for the development of the type 2 diabetes in Indian patients. See, despite so much of advances in the treatment algorithm, the glycemic target in diabetes patient abroad and India is still very dismal. You know, the average HbA1c in India is thought to be around 8.6%. And that means there is an urgent need of appropriate treatment for the Indian diabetics. Now, what we want to do, we have to tackle not only the diabetes, the numbers, the sugars, we have to control both diabetes as well as the dyslipidemia along with the blood pressure management. And we know the early and appropriate treatment for both of them, the diabetes and dyslipidemia, is mandatory for a better cardiovascular outcome. Let's focus upon the diabetes. You know, we know that aggressive glucose control from the very beginning, leaving a good glycemic legacy, is helpful for the patient to maintain the less incidence of the cardiovascular complication. The important factors the physician should know while choosing anti-diabetic therapy, whether you have to be more stringent in making the HbA1c less than 7, between 6.5 to 7, or you can go for the less stringent HbA1c, because one size does not fit all. Like, for example, we have to be more stringent in patients where there are no risks associated with the hypoglycemia, where the disease duration is short, newly diagnosed, where the life expectancy is long, where the important comorbid conditions are absent, where there are no established vascular complication, and the patient is highly motivated, excellent self-care capabilities, and there are readily available resources support system. These are the patients who should be aimed to get HbA1c of less than 7, even up to 6.5. But opposite to that, we had to be less stringent, and we can keep the HbA1c anywhere between 7 to 7.5. So these are the determinants of the glycemic target in the patient with type 2 diabetes. Over the years, we have been very conventional approach in treating diabetes, what we call the treat to failure. We used to treat failure. We used to get one medicine for some time. The patient's HbA1c was not on target. We used to add another, then third. But nowadays, we need that the intensification of the treatment right from the very beginning has to be there. But early aggressive treatment will maintain or decrease the long-term metabolic, cardiometabolic complications. There has been some reasons that why the physicians are not intensifying the treatment as early as possible. The patient-related factors, because the two important factors is the pill burden, the cost of the therapy, and the treatment-related factors is the clinical inertia from the point of the physician and dropouts of the patient due to multiple pills. So what we want to say that what is the harm if we continue to delay our intervention in terms of the aggressive control of diabetes right from the very beginning? Because this is a very important graph, a cartoon, where it has shown if the patient remains with an HbA1c of more than 7, who is not receiving the intensive treatment within the first 1 year, imagine at 5.3 years, that patient has a significantly increased risk of MI up to the tune of 67%, stroke 51%, heart failure 64%, and the composite cardiovascular endpoints of 62%. Now let's see what best we can do to treat these diabetes to make them on target right from the very beginning. We have been giving metformin as the first line of therapy, and we have been advocating the use of combination of a metformin and the gliptin or DPP-4 inhibitor right from the very beginning, because there has been ample evidence to show that the FDC of a metformin and the gliptins, even at the baseline HbA1c or 7.5, is helpful in reducing the long-term diabetic complication. Let's see the FDC of the drug with the gliptin should have a metformin. We should have a longer extended duration of action. You know, the metformin is a high half-life of 5 hours, and metformin is not metabolized and excreted unchanged in the urine. And the renal clearance is 510 plus minus 120 ml per minute, and is highly water soluble. Now, I was talking about the fixed dose combination of the metformin with gliptin because the simple and effective way to achieve glycemic target is the early and proactive use of the appropriate fixed dose combination, what you call the FDC, not only reducing the pill burden, also causing the cost containment and having less side effect with the complementary mode of action of both the drug. Most of the leading organizations say that the FDC or the combination should be started with the HbA1c of 7.5, or if your patient HbA1c is more than 1.5% of the target value. So that was the ADA, but the ACE guideline says that even at the HbA1c of 7.5, you can use the combination therapy. Now coming to the combination therapy, we have the available options with the gliptin, and the only one fixed drug combination having the metformin extended release, not for the immediate release in one pill, which can tackle the issues of the better 24 hours control, is with the sexagliptin and the metformin extended release. The unique gel matrix shield diffusion technology of this particular tablet, you can see the beauty of this tablet, release of the sexagliptin and metformin in patient with type 2 diabetes. First, the sexagliptin outer core dissolves immediately, exposing the inner core, and the gastric fluid enters tablet, causing polymers to hydrate and swell, forming a gel matrix, and then metformin diffuses through the gel and is slowly released over the 24 hours time. So that means the metformin XR pharmacokinetics shows that it delivers approximately 90% drug within 30 minutes and approximately the 90% of the metformin extended release. The 90% drug in 30 minutes was for the immediate release, and the 90% metformin extended release over about 10 hours. See the difference of the release when the patient takes the pill. And the Tmax is a median of 7 hours, and the area under curve is similar to that of the metformin immediate release. Why this metformin extended release? What is the advantage? You know, there are less GI events with the metformin extended release as compared to the immediate release. So we had to have some drug technology, we can reduce the side effects which are associated with the metformin. And also, it has been shown that patients who are transferred from the metformin immediate release to the metformin extended release is the population-based study. It was associated with the increased adherence as compared to the metformin immediate release, and also the HbA1c improved from 9.1% to 8.4%. So that is the good thing about this extended release of the metformin. About the glycemic control or the glycemic variability over the 24 hours, we have the CGM data, which has shown that Combiglyze XR or the sexagliptin with the metformin accident release produces significant reductions in the average blood glucose concentration over the 24-hour dosing interval without causing any hyper and hypo episodes. And also, if you compare the metformin extended release, a single tablet vis-a-vis, you compare with the metformin extended release up titration. Up titration means you keep on up titrating the dose of the metformin. You can see that a single tablet of sexagliptin metformin extended release as compared to the metformin alone with an up titration of the doses, the addition of the sexagliptin is much more superior as compared to the metformin extended release alone, even if you up titrate the dose to bring down the HbA1c level to the normal. Having said that, we need to have an aggressive control of diabetes from the very beginning, and we have some solid data like verified data with the vildagliptin. So we should consider the combination of a gliptin with extended release to have a true 24 hours glucose control coverage. Now coming for the dyslipidemia, we should not forget that only controlling diabetes is going to help. It is the lipids which carries an important thing to prevent the cardiovascular death in diabetic patients. Now let's see the demographics or the geographical or the epidemiological distribution. Patient on statin who can achieve the LDL goal are hardly what you call the 49%. And patient on statin plus other lipid lowering agents, they could not achieve the lipid targets, and 46% could not achieve the lipid targets. That means we had to do something more than that. We had to be more aggressive in lowering the LDL as low as possible to prevent the residual CHD risk and also to prevent the what you call the cardiovascular death and the progression of the ASCVD. So there is a need of appropriate treatment for the Indian diabetic dyslipidemia, and I'll be elaborating more on the Indian diabetic dyslipidemia, why it is important. Because in comparison with the Europeans, CVD affects Indian almost a decade earlier. 10% of the heart attacks occurs in Indian less than 40 years of age, and 50% of the CVD deaths occurring under 70 years. In the inter-heart study, dyslipidemia appears to be the strongest contributor for acute myocardial infarction in India. There's a beautiful study in the Lancet way back in 2015, where they could show that reduction of the 39 milligram LDL by statin from the baseline reduces 21% risk of the major vascular events, any death 9%, any vascular death 12%, major coronary events by the tune of 24%, coronary revascularization 24%, and stroke by the tune of 15%. Now what the guideline says, what we have to do to bring down the LDL to the target goal or as low as possible. The two leading organizations, the European Society of the Cardiology and American College of Cardiology, in their latest guidelines, the 2019, both of them are showing that identify LDL as the main primary target of the therapy. Lower LDL cholesterol is better with the proven pharmacotherapy and with better lifestyle habits. And both the leading organizations, they emphasize 50% or more lowering of the LDL and also identify specific values of LDL to trigger the further clinical action. Each set of guidelines in addressing the primary prevention population is the estimation of the cardiovascular risk through accepted risk scoring system. We often apply the ACC, AHA, ASCVD risk stratification by telling them what goal you have to achieve. A diabetic patient with or without dyslipidemia can be categorized into having the moderate to high severe risk as per the ESC guideline. The high risk patients, diabetes with the target or without target organ damage with duration of more than 10 years or another additional severe risk factor. While the very high risk category are those with diabetes with target organ damage or at least 3 major risk factors or early onset of type 1 diabetes or long duration more than 20 years. So the European Society of the Cardiology came with the risk stratification in 2020. And before that, I will tell you that even before that, in 2016, the Lipid Association of India, which is a leading organization recommending the lipid treatment guidelines, had published their consensus guideline in 2016 only, where they have set the target of the LDL to less than 50 in patients with the very high severe risk. And then came after that the European guidelines where they have set the target, the minimum target of less than 55 in patients of the very high risk. And the very high risk patients are those with ASCVD, with the family history of ASCVD, severe renal failure, diabetics with target organ damage, with more than 3 severe risk factors, and a type 1 diabetes more than 20 years of duration. As compared to the high severe risk, markedly elevated single risk factor in particular, depending whether total cholesterol is more than 300, LDL is more than 190, or BP is more than 180 by 100, moderate renal function, more than 10 years of diabetes duration. In 2020, when the European Society guidelines published their risk stratification, LAI was further aggressive in giving the 2 more risk stratification apart from the low, moderate, high, and very high risk. They came with the new category called extreme high risk patient, category A and category B, where they could say that minimum target of LDL should be kept less than 30, not less than 50 or 55. The category A was the patient with the more than one feature of the very highest group plus the CAD, and the category B, CAD with more than one feature of very highest risk group or recurrent acute coronary syndrome. So what should we do in order to, when we risk stratify the patient with diabetes? Separate the patient with diabetes, no ASCVD, and diabetes with ASCVD. Diabetes with no ASCVD, very high risk, keep the goal of less than 50, which is corresponding to 55 of European Society of the Cardiology, and the high risk patient keep the LDL goal of less than 70. This is with the patient with have no ASCVD. Diabetes with ASCVD, having less than 1 ASCVD risk factor, you have the option of keeping the LDL as low as 30 or even 50. But if the diabetic with ASCVD has more than 2 ASCVD risk factor, you have to keep the LDL as low as 30. We have ample evidence to show why we want to keep the LDL as low as possible. Now, choosing the right status, right from the many decades, we have a lot of trials showing that lower the better, lower the LDL, better the cardiac event rate. I know up to 60, you had a IT trial where the atorvastatin 80 milligram was chosen to bring down the LDL down to the 60 milligram. And how to attain a good LDL lowering? We have 3 categories of dosing of these statins: low intensity, moderate, and high intensity. Normally, the diabetics who are kept at the moderate to the high risk, I think we should keep the all diabetic patient in LDL goal of less than 70 and very high risk less than 50 and extreme high risk to less than 30 LDL, which you can achieve by giving a high intensity statin therapy, either 80 milligram atorvastatin or the 40 milligram rosuvastatin, which can be given to the patient with very high risk category. A word about the use of statin in the kidney patient, depending on the eGFR. We often forget that how we have to modify the use of different statin depending on the eGFR. Fluvastatin is the only statin which does not require any dose adjustment. Rosuvastatin cannot be given more than 10 milligram in patients of eGFR between 15 to 30. Same is with the simvastatin. And then pitavastatin is the drug you can't give more than 2 milligram in the eGFR or less than 60. So this has to be kept in mind. So I was telling why the Lipid Association of India was very much, aiming to bring down the LDL as down to the less than 30 in extreme high risk category type B. In 2019, the Colancio and colleagues had shown incident ASCVD event rates threefold higher in those at very high risk versus those who are not at very high risk. Among the very high risk category, those with the multiple ASCVD events had subsequent event rate that were 5 times higher. And the Lipid Association of India has said that 50% of the cardiac deaths occur before the age of 50 and 25% of the myocardial infarction occur before the age of 40. What are the benefits of the lower target? What are the evidence from the trial? Improve IT trial had shown 6% relative risk reduction with ezetimibe added to the simvastatin in patients with the recent acute coronary syndrome among the 971 patients achieving an LDL target of less than 30 with a combination of simvastatin and ezetimibe therapy. 4-year trial using PCSK9 inhibitor evolocumab showed that statin-treated ASCVD given evolocumab, ASCVD risk reduction was successfully lower with lower LDL cholesterol compared to the patient LDL more than 100, and the lower LDL cholesterol was even attained even less than 20 milligram. Odyssey trial had also shown 26% reduction ASCVD who achieved the LDL goal between 25 to less than 50 and also between 25 less than 25. Then lastly, but not the least, the meta-analysis of cholesterol treatment trial is collaboration statin data and other non-statin trial among population with average LDL levels averaging 65 milligrams showed further risk reduction if LDL was kept down to 21 milligram. Now, despite achieving the LDL goal of 30, it is surprising to note that patient has still residual CV events. So do we have to look into the other lipoprotein molecules in view of the high prevalence of atherogenic dyslipidemia in our country? A look on the triglyceride and non-HDL level in Indian dyslipidemic. What the Lipid Association recommends that you can do both fasting and non-fasting lipid profile and maintain a TG of less than 150. The flow is that in the first visit, you can do both fasting and non-fasting. In the second visit, also you can go for fasting and non-fasting because both fasting and non-fasting lipid profile should be known. A fasting lipid profile or the direct LDL measurement is recommended to judge whether LDC goals have been achieved and to determine the need for additional LDC lowering. A non-fasting lipid profile is required to determine post-parenteral elevation of the triglyceride level. This is a beautiful algorithm how to treat the high triglyceride. The use of statin plus ezetimibe along with the fibrates or omega-3 fatty acids are recommended when the TG goes more than 500. Below 500, there is no need of add a fibrate or micronized phenofibrate. You can even treat with the omega-3 fatty acid. And if it is more than 1000, you have to increase the dose of omega-3 fatty acid and continue with the fibrate or rule out some other genetic causes of very high triglyceride level. The LAI also recommend HDL cholesterol should be kept as the co-primary target apart from the LDL as a primary target. and for the prevention of the both future in primary and secondary prevention of atherosclerotic cardiovascular disease. Now, a word about the particular molecule, the rosuvastatin, whether we can compare with the other existing statins. The Uranus trial was the only trial which has shown that rosuvastatin was more effective in reducing LDL cholesterol and LDL-HDL ratio and non-HDL cholesterol vis-a-vis atorvastatin at 16 weeks of the therapy intention to treat population. Also, it showed that percentage of patients achieving LDL cholesterol goals at 4 weeks were higher with the rosuvastatin group. Now, how can we achieve? When we are using a statin, you have to know about the innovator as well as the generic. There has been some, talk between the generics and the innovators, but the first direct evidence which came from the Spain in the Journal of Lipids in 2018, where they had shown that compared to the brand name statin, the probability of suffering a CV event for generics were higher on an average of 31% during the 5-year follow-up. And also it correlated with the adjusted probability of all-cause death, which was significantly higher in the generics. Why this is important? Because the stability of the innovator research rosuvastatin formulation is important, because there are some impurities which can be formed during and after production of rosuvastatin, and these can impact the stability of the rosuvastatin. That is important. And what are the impurities? The first paper to tell about the impurities in the generics versus innovator came in 2013, the Journal of Clinical Lipidology, where they found that generic atorvastatin was showing a lot of impurities in terms of methylated atorvastatin, and this impurity was shown to have no inhibitory effect on HMGR enzyme activity, and this presence of this impurity is widely available versus a generic atorvastatin may compromise global efforts toward the effective management. So we have to see the generic versus the same is true with the rosuvastatin. The stability is important because the impurities may change the stability. It can impact the stability resolution formulation and overall the shelf life. With this, my main aim was telling that the choice of statin, whether it matters or not, what is unique about Indian diabetic dyslipidemia, how our target differs from the European Society guideline or the American Diabetic Association guideline. We have come a step further to include a separate risk stratification of extreme high risk group, where we want to keep our LDL as low as 30 with a lot of evidence from the literature. So in near future, we will try to follow our lipid association guideline, and which these guidelines have been endorsed by the various organizations, has been published in the Journal of Lipidology, which is the very good journal lipids. And I'll be happy to take any question or answer during the panel discussion. Thank you very much.
Thank you, Subhash. Thank you so much for a wonderful presentation. You gave a very nice overview. Just one question. Should every diabetic take a statin independent of his age?
Absolutely. See, recent LAI guidelines, we had a consensus guideline. The first cutoff age was at 20 years that you can start statins more than 20 years. But recently we have come that because of the early onset of the CAD and the early onset of the diabetes and the young type 2 diabetes, it is mandatory to keep the lipid goals as low as possible. And you can even start statin even below the age of 20 years. At any age, you are bound to give the statins to bring down the LDL level to the target goal.
Thank you so much, brother, for joining our meeting. As you know, right now also 52,000 people have heard your talk, and I hope your pearls of wisdom go a long way. You highlighted a very important point that diabetes is not just about glucose management. It is equally important to handle them from a cardiovascular standpoint. So thank you so much. Thank you, Chandni, for co-chairing it with me. And now I ask Dr. Hina Goswami and Dr. Tanuja Shah. Dr. Hina Goswami is a diabetologist and endocrinologist from Jamnagar, and Tanuja is a diabetologist from Mumbai, and they will start the next session. Thank you, Subhash. Thanks, Satan, once again.
Thank you, Shashank.
Thank you, sir. Good morning, everyone. Thank you for the opportunity, Joshi sir. Our first speaker today is Dr. Shubhankar Chaudhary sir from Calcutta, a renowned endocrinologist. Over to you, sir. Dr. Shubhankar Chaturvedi, sir.
Yeah, I have a recorded talk. This will be played, I'm sure, but I'm available to take questions at the end.
So Professor Shubhankar Chaudhary is the professor and head department of IGPMR. He has been the editor of our Indian Journal of Endocrinology and Metabolism. He's one of the foremost endocrinologists in the country. Anirudh, if you could start his recording.
A very good morning. Greetings from Kolkata to the 21st International Symposium on Diabetes. This morning, I shall discuss a very important concept, the use of fixed dose combination in management of type 2 diabetes. And actually, I'll be talking of the first metformin, SGLT2 inhibitor, and DPP4 fixed dose combination in India, and see how it fares in management of diabetes in our context. So we do understand that there are some special needs. I wouldn't say peculiar, maybe special needs in Indian type 2 diabetes management. Of course, when we talk of the ABC, maybe we talk of A1C, blood pressure, and cholesterol. But here I have made it A, B, C, D, and E, of which A is glycemic control, A1C lowering, B is beta cell preservation and durability of treatment, C is how to address clinical inertia and complications, D is diligence towards treatment or adherence to treatment, and E, extremely important, especially in our part of the world, that is ease and economy of therapy. So we know one of the major causes, important causes for people not to continue with treatment is the mounting cost of treatment. So we need to have something which is easy to take, which is relatively pinches less on the pocket, and of course is efficacious and has durability of treatment. So we all are aware that in our context, people at diagnosis of diabetes and even several years down the diagnosis present with poor HbA1c levels. We see different studies, they are at 8.9, 9, 9.95. So all of them are way above our target of 7%. So we really need to do something to improve the A1Cs in our patients. And if you look at the real world evidence, this study, this is the TITE study, real world evidence of glycemic control among patients with type 2 diabetes in India. It's a large, of course, a retrospective record-based study, but it showed that 77% had A1Cs above 7%. About 62% had A1Cs between 7 and 8%. And at least 1/3 of these individuals had microvascular complications. So we're looking at large numbers, 55,000 individuals, and poor glycemic control, and as a consequence, high rate of microvascular complications. So how can we improve that? Now, if we look at sort of the pathogenesis of type 2 diabetes, we all know about insulin resistance and beta cell dysfunction. We are now made aware of the fact that even incretin effect starts to dwindle even before the onset of clinical diabetes, maybe 5 years, even 10 years before. And along with beta cell function starting to deteriorate, we have incretin effect deteriorating. The two, of course, also may be interrelated in terms of pathogenesis. And we know of the sequential approach, the standard approach of treating diabetes, starting with maybe just diet and exercise, then half a tablet, then 1 tablet, then 2 tablets, 3 tablets, 4 tablets, eventually going on to insulin. And there is a significant inertia at each step to further intensification. And we all know the main aim of treating diabetes is to prevent complications. And this sort of procrastination is one of the important reasons why we continue to see so many complications related to diabetes, despite the availability of more and more new agents. So this clinical inertia is something that's killing many of our patients. The other part, of course, is low adherence to treatment, whether it's at the primary care or even at the tertiary care level. We are also aware that many of our diabetics need large number of medications, especially non-diabetes related medications, especially those who are more than 65 years of age. The light gray bars represent those above 65, slightly darker gray bars represent those less than 65, and the black bars represent the total numbers. So the total number of tablets, more than 8 tablets, is seen in a significant proportion of patients, at least 20% of patients with type 2 diabetes. And if we look at specific anti-diabetic drugs, even that many individuals will be having more than 2 or less than 4 tablets, maybe 2 or 3 or 4 tablets, many of the patients will be on. So this is an important issue of pill burden that needs to be taken into consideration for successful management of type 2 diabetes, not just the glycemic efficacy of an agent, not only the safety or the side effect profile, but this is an important consideration. And that brings in the concept of fixed dose combination. And moreover, as we understand today, the diabetes mechanism or pathophysiology is not just insulin resistance and beta cell dysfunction, but something beyond that, with the kidney, the intestine, the brain, and all the different organs, even the alpha cell of the pancreas being taken into consideration. So the aim of treatment, of course, is to obtain early and sustained glycemic control, which will likely, hopefully, minimize the legacy effects of hyperglycemia and therefore minimize the risk of complications. And if we use early multiple agents, we may be able to target multiple pathophysiologic factors and therefore be better able to get the glucoses under control quicker and possibly on a sustained manner. Hence, once again, the scope for fixed dose combination of drugs acting at different components of the pathophysiologic makeup that we have seen. So combination therapy should include agents that have complementary modes of action. Same mode of action, 2 or 3 drugs taken together, put together, of course, doesn't help. And they provide additional advantages in that they help attain glucose target earlier, better, and hopefully reduce complications and reduce disease progression. And of course, the issue of compliance is there with reduction of pill burden. So we do have so many different types of drugs today to combine. We have, of course, still metformin as the sheet anchor, which may gradually be losing its place to other agents like SGLT2 inhibitors, but we have to complement metformin, we have sulfonylureas, DPP4 inhibitors, SGLT2 inhibitors, pioglitazone, GLP-1 receptor agonists, insulin, and we also have alpha glucosidase inhibitors. So if we consider the drug classes for combination therapy, green means something which is favorable, which is good. Yellow means which is moderate, not very good, but it's reasonable. And red is sort of be aware there could be issues, there could be concerns with this. So if we look at the different factors like efficacy, hypoglycemic risk, effect on body weight, safety and tolerability, cost of therapy, and cardiovascular benefits. I think metformin remains the champion in that it gets a blue tag for most. Of course, it does have a yellow tag because of some individuals having significant GI side effects. If you look at DPP-4 inhibitors, again, they have a good sort of marks, except for the cost of therapy. But again, DPP-4 inhibitor cost in our country has come down very significantly. SGLT2 inhibitors, again, cost is an issue, used to be an issue, but again, in our country, cost is no longer a major factor because of various factors. Availability of newer SGLT2 inhibitors not available elsewhere in the world. And so if we combine these metformin, DPP-4, and SGLT2, we tend to get a very effective combination with high A1C lowering efficacy, low hypoglycemic risk, neutral on body weight, or even possibility of reduction of body weight because of presence of both SGLT2 and metformin together, quite safe, except possibly for the GI side effects of metformin and the risk of genital mycotic infection with SGLT2. But that also, it has been suggested that if you use a DPP-4 inhibitor and SGLT2 inhibitor, maybe the risk of genital mycotic infection also comes down. Cost of therapy is a consideration, but as I said, with these fixed dose combinations coming in, the cost has come down and cardiorenal benefits are there as it's provided both by, especially by SGLT2, possibly also by metformin. So clearly, these three agents could form very good partners in our therapeutic armamentarium. And if they could be provided in a single tablet, a fixed dose combination, then of course the pill burden could decrease. And we all understand that various august bodies, including the American Association of Clinical Endocrinology, have suggested that if the entry A1C level is significantly high, above 7.5, but within 9%, it could start with a dual therapy or even in a triple therapy, meaning the starting is metformin is there, and on top of that, you could add either two more agents or one more agent. If it's two more agents, then GLP-1 receptor agonists are there, but they are not oral agents. And we all know the struggle that we have every day to get patients to accept injectable forms of treatment. So clearly, the first choice for us, for most patients, would be some sort of an oral agent. And SGLT2 and a DPP-4 inhibitor could be an excellent combination along with metformin in those coming with entry A1C above 7 point, maybe between 7.5 to 9%. If they're above 9%, even then we could sometimes use triple therapy, provided patients are not grossly symptomatic. So this clearly lays the foundation for triple therapy and maybe as a fixed dose combination. And if you look at US FDA, which actually has not approved any fixed dose combination in the past, only to approve two fixed dose combination of three oral anti-diabetic agents, one in 2019, the other in 2020, and both of them had as essential components a DPP-4 inhibitor, an SGLT2 inhibitor, and metformin. The one was Boehringer and Lilly's IMPA-LINA metformin combination. The other was AstraZeneca's TAPA-SAXA metformin combination. So triple drug oral anti-diabetic agent is approved by US FDA, and we can, by combining these three agents, cover practically most of the pathophysiological effects of the ominous octet that Ralph DiFranzo has already mentioned about. And because of the complementary actions, they are likely to be more effective and provide significant and durable reduction in glucose. They're likely also to provide cardiorenal benefit and possibly hepatic benefits as well. There is a lot of people out there which suggest SGLT2 inhibitors, even to a certain extent for DPP4 inhibitors, that they could have a favorable effect on NAFLD, which is a very common passenger with type 2 diabetes. And then this could provide beta cell preservation. They do not have overlapping toxicities, and they do not have any drug-drug interactions. Very important for us. They are available for oral therapy, and they are cost effective. So metformin, SGLT2 inhibitor, DPP4 inhibitor, excellent combination so that we have an effective agent without us having to be worried about the risks of hypoglycemia, worried about the risks of weight gain, which would otherwise happen with the existing triple drug OADs that we have, which have sulfonylurea in it. No doubt that they are very effective, but they bring with them the problem of hypoglycemia and weight gain, but not with this particular triple drug combination. And so one such combination that I shall be talking about is Remogliflozin, which is an SGLT2 inhibitor, which is developed essentially to a great extent by an Indian company, along with DPP4 inhibitor, Vildagliptin, which has become off patent, has become generic, and so the cost has dropped significantly, along with metformin. So this clinical development, this is the first such SGLT2 inhibitor-based triple drug fixed dose combination. So the Remo began its journey more than 2 years back, 2.5 years back, when first Remogliflozin was approved by our DCGI. And then 6 months later, metformin Remogliflozin combination was approved. Then a Remogliflozin and Vildagliptin combination came another year later. And a few months back, 4 months back, in September 2021, our DCGI, or the CDSCO, approved the metformin Remogliflozin Vildagliptin combination. So if we try and look back at how it was approved, well, for fixed dose combination, the requirement is to provide pharmacokinetic assessment and provide pharmacodynamic assessment as well. So in order to do that, what it has been done is that one has looked at the Remo-Vilda combination, which is approved, a Vilda-metformin combination, which is well approved since long, and Remogliflozin and metformin combination. And we shall look at the results of these important studies. And for the pharmacodynamic assessment, we shall look at the results of the FOREVER study, and I'll go through them quickly. So if we look at the Remogliflozin and metformin drug interaction and bioequivalence study, there is ample evidence that the curves, whether you take Remogliflozin and metformin separately versus Remogliflozin metformin combination, fixed dose combination, the curves of Remogliflozin level over time is practically superimposed on one another, suggesting that Remogliflozin does not affect the pharmacokinetic profile of metformin or vice versa. Similarly, we have similar figures for Vildagliptin metformin combination versus individual agents taken separately. Once again, absolutely no effect of one drug on the other in the same fixed dose combination. And Then again, with vildagliptin and remogliflozin taken together or separately, the curves exactly superimpose, giving us confidence that vildagliptin does not affect the bioavailability of remogliflozin or vice versa. And then we come to this phase 3 clinical study for fixed dose combination of remogliflozin vildagliptin for efficacy and tolerability versus a very well established combination from a multinational, the empagliflozin linagliptin combination. So remo-vilda combination being compared against empa-lina combination in this forever study carried out across 23 sites across India for specifically for our patients with type 2 diabetes. And what was found was that, and metformin, of course, was continued so that it gave, in essence, 3 drugs for each group. And the duration of follow-up was up to 16 weeks, followed by a 2 weeks follow-up. And it found that whatever population and whatever analysis we do, the remo-vilda combination, 100 milligrams of remo and 50 milligrams of vildagliptin, of course, it has to be taken twice daily versus standard empa-lina combination, 25 milligram versus 5 milligram taken once daily. We find that the patients were all matched at baseline in terms of age, body weight, or baseline HbA1c or fasting or postprandial glucose levels. And if you look at the glycemic efficacy, the A1C reduction, whether it's at week 6 or week 12 or week 16, absolutely no difference numerically. Actually, removilda tends to be doing slightly better, but of course, this is not to claim superiority. This is just to show that this is non-inferior to the established empa-lina combination, but of course, at a much cheaper price. And similarly, for fasting glucose, we have similar figures, and for postprandial glucose. So clearly, from glycemic control point of view, this removilda combination seems to be working excellent, at par with the empa-lina combination. What about body weight reduction? Once again, if we compare the two combinations, they work absolutely similar. Similar is the figures for blood pressure reduction. So not only glucose control, but also in terms of body weight reduction and blood pressure reduction, they work very similar. In terms of adverse events, once again, they are very similar. And we won't go to through the list, but it did not show any significant higher incidence of any of the adverse events. And similarly, for urinary tract infections or genital mycotic infection, there was no significant difference. So the conclusion was that the triple drug therapy of metformin with remogliflozin and vildagliptin provided early and consistent glycemic reduction. So not only just at 6 weeks, but even at 12 and 24, 16 weeks, it showed significant reduction in A1C. Significant extra glycemic effects like weight and blood pressure reduction was also there, and not associated with any additional safety risk, offers low hypoglycemia risk, and have been found to be comparable to the combination of empa-lina with metformin, with demonstrated non-inferiority. So, ladies and gentlemen, therefore, we bring before you a new option, relatively cost-effective option of vildagliptin, remogliflozin, and metformin in managing your type 2 diabetes patients who are uncontrolled, maybe on metformin only, or maybe on 2 drugs. So clearly a fixed dose combination could go a long way to provide glucose control and protect organs in the long run. Thank you very much.
Thank you so much, sir. Wonderful talk. We will be taking the question answers at the end of both the lectures of this therapy sync. Dr. Tanuja?
Yeah,
You can
hello.
take question answer after both the sessions.
Yeah. Hello, everyone, and a warm welcome. All questions, as he said, will be taken after both the therapy symposium. Let me introduce Dr. Banshi Sabu, who will be the next speaker. Dr. Banshi is a senior, well-known diabetologist from the city of Ahmedabad. He is a past president of RSSTI also. Presently, he is an organizing secretary for the IDSI 2022. He will be talking on the clinical implications of glycemic variability and the TOP-TIR study. Over to you, Dr. Banshi, sir, and you can start the recorded message. Thank you.
My topic is clinical implications of glycemic variability, and then I will be talking about the TOP-TIR study. This talk is supported by Glenmark, so I'm thankful to Glenmark for supporting this activity. We know that glycemic assessment in diabetes has moved beyond A1C. Now we just can't depend only on A1C. We know that it is a standard parameter for assessing glycemic control in patients with diabetes, but there are several limitations of A1C measurement. HbA1c alone cannot assess the hypoglycemia or glycemic variability. HbA1c does not provide information on frequency, duration, or magnitude of short-term fluctuation in glycemia. HbA1c does not reflect intra or interday glycemic excursion. HbA1c gets easily affected by conditions like renal disease, hemoglobinopathies, chronic liver disease, or iron deficiency anemia. And HbA1c may not exactly reflect the glycemic exposure. So actually our paradigm is shifted. We used to monitor only A1c, fasting plasma glucose or postprandial glucose level. That is what we used to call it glycemic triad. We moved from glycemic triad to glycemic pentad, where other than A1c, fasting plasma glucose and PPG, we are looking for glycemic variability and also hypoglycemia. So now our paradigm is completely shifted in diabetes management from glycemic triad to glycemic pentad. What's glycemic variability? It's a better predictor of hypoglycemia than A1c. It's a consistent predictor of hypoglycemia. Hypoglycemia is associated with significant morbidity and increased mortality. Frequent or large glucose fluctuation independently contribute to diabetes-related complication. And increased glucose variability is associated with mortality in ICU. If we see the glycemic variability, there is a substantial role of glycemic variability in development of complication. Particularly, there are increased risk of severe hypoglycemia with more glycemic variability. With more glycemic variability, more risk of cardiovascular events, increasing risk of cardiovascular autonomic dysfunction. More of glycemic variability also increases the risk of microvascular complication, and increasing glycemic variability also have risk of increasing macrovascular complication too. The glycemic excursion actually trigger oxidative stress, and this remain as a more the glycemic variability, there is an increased risk of increased intracellular reactive oxygen species, which cause defective angiogenesis, activate pro-inflammatory pathways, and long-lasting epigenetic changes. Thus, continue even in the normoglycemic state, there is a hyperglycemic memory will be there if there is an increased glycemic variability. This you can find with the continuous glucose monitoring, because a person or three different type of person with the same A1C of 7 or 7.5, they may have different type of time in range. The time in range means out of 24 hours, how much percentage of the time person is remaining between 70 to 180. So you may have three variety of patient whose A1C is around 7 or 7.5. But one person may have 100% of the time, the sugar is remaining in range between 70 to 180. The other person may have 70% of the time, it is in range, but 25% of the time it is having hyperglycemia excursion, and 5% of the time even it is going below in time in range. You may have again a similar patient with A1C of same, but again 40% is remaining only in range, 40% is hyperglycemia, and 20% of the time person remaining in hypoglycemia too. So actually A1C does not give you complete picture. It can be only monitored through continuous glucose monitoring, and we can find out that how much time person is remaining in range, how much time it is below range, and how much time it is above range. So actually, along with A1C, if we get the CGM or a continuous glucose monitoring, it gives us a complete picture where the patient have a glycemic variability. It is now recommended from the international consensus on the use of continuous glucose monitoring, which is published in Diabetes Care 2017. I was one of the author as well as expert for making this consensus of recommendation on use of continuous glucose monitoring. It is to be for 7 to 14 days. The percentage of the time, it is 70% of the time. It gives you the mean glucose. It also gives you the glucose management indicator, that is GMI. It also have glycemic variability, which should be less than 36%, so 1/3 of the time. Time above range, if it is more than 250, we call it time above range, level 2 hyperglycemia. If it is more than 180, we call it level 1 hyperglycemia. Time in range is more than 70% of the time. It should be in 70 to 180. That is what we call its range. Time below range, when it is below 70, but it should not be less than 54, that we call is level 1 hypoglycemia. And time below range, when it goes below 54, it is called level 2 hypoglycemia. So this is what is been recommended. And ADA 2021 guideline also incorporated these recommendation too. They had talked that 70% of the time and more than 70% of the time, one should remain in the range of 70 to 180. It is not acceptable if the sugar goes more than 25% of the time, more than 180. And out of them, if it goes more than 5% of the time, more than 250 milligrams, then it is not acceptable. And we should try to change the therapy in such a way that person should be more in time in range, in target range of 70 to 180, and it should have less and less time above range. The other thing is regarding the sugar, when it goes in hypoglycemia, level 1 hypoglycemia, if it is less than 70, it is not acceptable that it should be more than 5% of the time. And it is not acceptable if it is more than 1% of the time, it goes below 54 also. So CGM is a more meaningful measure of glycemic control, and it is a standardized metric for clinical care where we can have a time in range, and we can know that whatever the patient is on medication, whether he's achieving time in range or he's achieving more than 70% of the time, between 70 to 180. If he's not achieving, we should change the therapy to achieve time in range. Why we should maintain the time in range? We know that A1C is directly more correlated with more microvascular and macrovascular complication, as this is a new parameter of a glycemic control. We don't have many data which is published for that, but we know that every 10% decrease in time in range, there is an increased risk of microvascular complication. It is increases risk of microvascular complication like risk of retinopathy by 60%, risk of microalbuminuria by 40%, and risk of peripheral diabetes, neuropathy by 25%. Even for carotid intima media thickness, a surrogate marker of cardiovascular disease, have also shown an association with time in range. So poorer the time in range, there is more increase in carotid intima media thickness also. This is a study which is a teneligliptin effect on a glycemic control through parameters of time in range, and we call it TOP-TIR study, which has been done at 3 centers. It is a prospective multi-center open label study to assess the effect of teneligliptin on glycemic control through parameters of time in range, metric using continuous glucose monitoring. The rationale of this study, as we know that teneligliptin is one of the most widely prescribed gliptin in our country. It is administered as a 20 milligram once in a day, but occasionally it is up titrated up to 40 milligram per day. There is a limited data that teneligliptin on time in range parameters in Indian type 2 diabetic patient. And that's why this study was planned to assess the effect of teneligliptin on glycemic variability using continuous glucose monitoring. The study objective was, the primary objective was to evaluate the percent of time in range in patients who are treated with teneligliptin. The secondary objective was to evaluate time above range, time below range, the glycemic control, and tolerability also. There were 3 sites, Dr. A.G. Unnikrishnan, my site at Ahmedabad, and again Dr. Subhas at Pune. The study drug was 20 milligram OD, and these patients was on metformin on a stable dose, which was continued, either of 1300 plus minus 356. So some patients were on 850 milligram twice daily, some patients were on 500 milligram twice daily, and some patients was on 500 milligram 3 times daily, but they remain on a stable dose of the molecule also. The study endpoint was day 1 to 4, it was baseline, day 5 to 14, it was post-treatment phase 1, and day 33 to 46, it is a post-treatment phase 2. The primary endpoint is, I told you, the change in time in range, that is the percentage of reading time within 70 to 180 milligram from baseline to post-treatment phase 1 and 2. The assessment of change from baseline to post-treatment phase 1 and phase 2 is a mean glucose value, glycemic variability. As I told you, time above range is more than 250, time above range, the more than 180, time below range less than 70, and time below range 54. And then we had seen the change in HbA1c, fasting plasma glucose, postprandial glucose level from baseline to 6 weeks, and incidence of any adverse events or serious adverse events, treatment emerged adverse events or treatment emerged serious adverse events were also seen in secondary endpoints. The patient criteria, inclusion criteria were any patients, male or female, type 2 diabetes, adult patient, but less than of 65 years of age. Type 2 diabetic patients who are uncontrolled on a stable dose of metformin, but their A1C was more than 7.5, and these patients were gliptin naive. The exclusion criteria, not the patient who are type 1, those who are on insulin, those who have a diabetes complication or history of diabetic ketoacidosis, hypersensitivity to the study product, or any patient whom the investigator judged to be inappropriate for the study. The study flow was, the CGM device was implanted on day 1. The teneligliptin 20 milligram was introduced from day 5. So the first CGM was day 1 to 15, no teneligliptin. From day 5 to 14, the patient was on continued with CGM, but patient teneligliptin was started. CGM device was removed on 15th day, but the data was captured and teneligliptin was continued till day 32. On day 33, again, a second CGM device was implanted. CGM was continued for another 14 days. On 46 days, CGM device was continued and CGM device was removed on day 47. So first CGM was between day 1 to day 14. The second CGM was day 33 to day 46. The day 1 to 4 was considered as a pre-treatment. Day 5 to 14 was post-treatment phase. This the second CGM was day 33 to day 46. Day 5 onward, teneligliptin was given continuously for a total duration of 6 weeks. A uniform diet plan was followed by all the patients as per protocol, and there was no addition of any other anti-diabetic drug throughout the study period also. The efficacy assessment of all primary and secondary glycemic variability endpoints between baseline to post-treatment phase 1 and post-treatment phase 2. Assessment of glycemic parameters like HbA1c, fasting, and postprandial glucose between baseline to end of study. And the safety assessment was monitoring and recording of all adverse events, serious adverse events, treatment emerged adverse events, and treatment emerged serious adverse events were captured for safety assessment. The results of the study. As the intention to treat analysis population, the patient characteristic, vital parameters, and biochemical parameters. So 59 patients were taken. The continuous glucose monitoring in a phase 1 was captured for 55 patients and 54 patients who have completed even pre-phase 1 and phase 2. So I mean complete completed the study were 54. So the analysis was done for 54, with 42 patients were having HbA1c between 7.5 to 10.5 at baseline. So we have taken then 42 patients who were considered for analysis. Now the glycemic parameter of 59 patients, if you see, the fasting plasma glucose of these patients at baseline were 183, with post-meal glucose level was of 241. On day 47, these patients' fasting glucose has decreased from 183 to 161, and post-meal glucose level has decreased from 241 to 211. The A1C decreased from 9.35 to the 8.48, and that has a significant p-value, even it has been measured only after 47 days. If you see the baseline demographic and analysis population between the HbA1c of 7.5 to 10.5, this number of patients were 42. The BMI, the patients who were day 1, 27.57, it is 27.61. High sensitive CRP was 3.72, it is 5.55. SGOT was 20.33, 18.67. SGPT 24.6, 21.31. Urea was 10.68, it has 11.57. Creatine is 0.74. It was here 0.78, plus minus, which I can show here to standard deviation. So there was no difference as far as p-value is concerned for all these parameters. But what are the parameters which had got a significant effect is the fasting plasma glucose from 175.99 plus minus 62.97 has decreased to 150.54 plus minus 63.47 with a p-value of 0.074. The post-meal glucose level is 220.68 plus minus 73.51, which is decreased to 196.91 plus minus 78.0205 with a p-value of 0.172. The A1C reduction from 8.6 plus minus 0.8 has decreased to 7.88 to plus minus 0.94 with a significant p-value. The CGM parameter, which is most important thing, as I told you, the glycemic management indicators. The average glucose level from 156 had come down to, in the phase 2, is almost like 139 with a p-value of 0.003 in phase 1, but in phase 2 it was 0.023 only. The glucose management indicator, which has gone down from 7.05 to 6.76, again a p-value of 0.003 in phase 1, but again in phase 2, because further decrease was not very significant, so 0.023, which is decreased from 6.76 to 6.664 plus minus 0.76. The glucose variability percentage, that is what GVP, 1.19 plus minus 0.07 has decreased to 1.16 plus minus 0.05 and 1.162 plus minus 0.07, which had got a significant p-value of 0.0001. If you see the percentage of time in range, it was 64.96 plus minus 24.35, which has actually increased to more than 70%, that is 75.07. That's a significant plus minus 17.57, which has got a significant p-value. The percentage time above range, above 180, from decrease from 31 to 22.43, percentage time above range like 6.97, which is more than 250 milligram, it has decreased significantly to 3.28. With time below range, there was no hypoglycemia, and time below range, when it is going below 70, it has also decreased too. The CGM parameter for 42 patients, the mean percentage of time in range has increased from baseline to phase 1 and phase 2, and from baseline to phase 1 with a significant p-value. Time above range is also decreased with a p-value of 0.003 or to the p-value of 0.0343 also in phase 1 and phase 2. The glucose management indicator has decreased from 7.05 to 6.76, and in second phase it has gone down to 6.642. The comparison of time in range between baseline, phase 1, phase 2 for patients with baseline time in range in less than 70%, there are 21 patients, and these patients had gone down from time in range was 45.81 only, and it has gone significantly improved from the only those patients whose time in range was less than 70 has increased to 73.98. And that has a significant p-value in phase 1 as well as in phase 2. So that's what a significant difference was. Those patients who were not achieving a time in range, after giving them teneligliptin, there was a significant improvement in time in range. The safety analysis of teneligliptin, it is well tolerated among all the patients, and there was no side effect which was reported. If I compare with other drugs, the teneligliptin, the study population was more than 7.5. We have a similar data with a canagliflozin in combination with teneligliptin, which is patients who were shifted from teneligliptin to cana, which is a switch group, and canagliflozin was added in the teneligliptin group. They are in a COM group. So we have patients with 48 and 51. And when teneligliptin was compared with placebo, that's a TEDdy trial with a 65 patients. The duration of these 3 trials, one the teneligliptin, which I had just talked about, it is of 6 weeks. The 2 combo trial, one was switch, another is a COM group of a canagliflozin with teneligliptin, and one was shifted from TEDdy to combo, canagliflozin. That trial was having HbA1c of 6.5 to 9. And when a TEDdy group, it was 7 to 9. The HbA1c reduction with the teneligliptin used by 0.87, and similar data we had seen in TEDdy group, which is 0.84. The time in range is improved from 64.96 by 10.72. And the similar, the teneligliptin group arm in TEDdy arm is also shown. The change from the baseline is 19.9. And that data which we had seen, there was a slight increase. Those patients who were switched from teneligliptin to cana by 5.8. But when cana was added in the arm of teneligliptin, there was 11.5 improvement percentage by increasing in time in range. The time above range is also decreased significantly in all these 3 groups. Time above range is also decreased, time below range is increased, and time below range less than 70 is also increased by that. To conclude my talk and the summary of this trial, the teneligliptin treatment reduces the glycemic variability. There was significant improvement in mean time in range at the end of study as compared to baseline. There was significant improvement in mean time in range at the end of study as compared to baseline. There was also significant improvement in mean A1C at the end of study as compared to baseline. Teneligliptin led to early glycemic improvement from baseline to phase within 10 days, and teneligliptin was well tolerated. Teneligliptin can be a very promising drug to reduce the glycemic variability in patients with type 2 diabetes. With this, I once again thank to Shashank and thank to Glenmark for giving this opportunity. Thank you.
Thank you so much, Bansi. We have both Dada and Bansi here. There are 2 questions in the chat group, which I'm just putting out to Dr. Chaudhary. Do you feel that SGLT2 impact what we see is a class effect? The question was asked yesterday also, and again they have asked you today, because cost is a major rate limiting step. And is there, how do we differentiate SGLT2 inhibitors? And the second question is again addressed to you, Dada, specifically from Dr. Sen in Siliguri. Do you think this triple drug regimen which you presented can be the first line therapy rather than using a SU based triple?
Great questions. Thank you. Regarding the first question, which is there in our minds, I think to a large extent it's a class effect. Because we've seen similar story for EMPA, for DAPA, for all actually, except for R2-glucosine, which, however, did not show as effective results, especially in the cardiovascular point of view. But for the renal point, I think they have been quite similar. So we can, of course, only speculate at this point of time in terms of remogliflozin, because it's matched very well, at least in its registration study, dapagliflozin, and then in this forever study, the comparison of Lina, EMPA versus Revo and Vilda. fared very similarly. So I feel it is likely to reproduce the benefits seen with the others, but we don't have hard data at this point of time. Neither do we see direct head-to-head comparisons in the near future as well. But I understand a lot of other studies have been planned, are in the pipeline to look at benefits of remogliflozin. Otherwise, maybe not as prospective studies, but maybe as real-world studies.
Nada, you're muted. Somehow you're muted. Can you just unmute?
Oh, sorry. Yeah. Sorry. So the final comments from me were that we expect remogliflozin will show similar effects. However, we do not have real hard data to show that, though the company has in plans, has already in works a number of studies, a number of at least real world studies. In terms of sulfonylurea based triple drug combination, I think this would be more favorable in terms of risks of hypoglycemia. So clinicians will have less concerns about prescribing it. In terms of efficacy, sulfonylurea based combinations would be preferred at least in the shorter term because they tend to be more efficacious. But in the longer term, possibly the differences are not great. I hope that answers.
Thank you so much, Dada, and thank you. Despite of COVID,
Thank you
I
very
can see
much.
that you are in your hospital. Thank you. We are very grateful. Next year, hope to see you in person, Dada.
We hope so. Yeah, thank you.
So
it was a great
Dr.
meeting.
Patil has asked a question. Thank you, Dada. Dr. Patil has asked a question similar to lines what they asked, Dada. That do you think that there is a difference in glycemic variability between different gliptins? And the other question he asked is, does once a day or twice a day gliptin matter? Because in combination, Dr. Patil is asking, you use it twice a day, and the same gliptin you use once a day when it is given alone. So does it impact glycemic variability? Because they feel you have done a lot of studies in that area. So that is the first question. And second thing is, again, Dr. Sen has asked the same question to you from Shiliguri, that do you think this is a class effect? Because cost matters in India, and particularly in rural hinterlands. So do you really feel that all gliptins are the same?
So Shashank, first for this,
is that for once a day, twice a day, which is reasonable, I think.
So Shashank, first of all, thanks for inviting me and thanks for this great question. All gliptins, I can say the second answer first. I would like to give that all gliptins are more or less same as far as their efficacy is concerned. What we are worried of is their safety data. And safety data, particularly after when you have a cardiovascular outcome trial of different gliptins, which has been done. And we don't have, unluckily, the data of cardiovascular outcome trial of neither of teneligliptin nor of vildagliptin, which is nowadays more popular because of their cost effectiveness, and we are using more in our patients. Now, efficacy wise, what we have seen that most of the gliptins have almost similar effect. And as far as glycemic variability is concerned, this is one of the trial which is teneligliptin has shown with the time in range. So one of the data from which we had shown a gliptin which is most popularly used in our country, we tried to show that whether it improves time in range or not. And that was our trial and study which we have done, TOP-TIR data. But there are data of vildagliptin, there are data of other gliptins also, where they had used to show that they also decreases the glycemic variability, and there is a decrease in glycemic excursion, which is there with that. So I believe that most of these gliptins are working in similar way as far as their glycemic variability is concerned and improvement in glycemic variability. Your question is that whether you are using twice daily, which is vildagliptin, instead of using vildagliptin's single dose, do we have a similar type of efficacy? Efficacy could be similar, but seeing their glycemic variability effect, we don't know unless you do the continuous glucose monitoring data. Internationally,
there's another question which has been asked on the similar line, Bansi. The question was not on once a day vildagliptin. They are saying that the same sitagliptin, the same teneligliptin, when you give it in combination, you split it into two.
Yes.
While otherwise you don't split it into two. So does it matter on the GI front? And the other question which has been asked is that US FDA banned 100 mg vildagliptin because of the hepatotoxic side effects. And yet we have approved it in India. What is the rationale? Was liver toxicity data done before approving the molecule?
It has not been done in India. Liver toxicity data has not been done. Even the same international brand they have introduced in India, but they have not introduced outside the country. They don't have the data. We should do ideally a phase 3 and safety data again in India to get. It is only on the efficacy basis it has been approved that 100 milligram is equally efficacious as 50 milligram twice a day. For Januvia, or I mean for sitagliptin or for other molecules, when we are breaking it into two, like and linagliptin also 2.5 and 500 milligram a combination, when we use it twice daily, they are equally efficacious because that pharmacodynamic.
So they want to know whether you have done study to show glycemic variability in them. Like for example, in teneligliptin, you have shown that a glycemic variability and time in range is excellent. Have they done such data? Because that data is not there. That's what is the question, the answer.
Yes, but that data is not there for CGM point of view. We don't have the continuous glucose monitoring. This is a new parameter, time in
like
range,
a first in kind
in 2019. So one of the first data which we have done.
So this is like a first of its kind study where you have shown, which actually even other gliptins don't have.
Yes.
I'm just going to take a quick comment from Dr. Panikar. Dr. Panikar was probably one of the first users of Remogliflozin and teneligliptin. What is your experience? Do you really feel these molecules make a difference?
I think they all work, like Dr. Bansi said very nicely. They all work and they are cost effective. Yes, now we have generic DPP4s and we have generic SGLT2s. So it's a different ballgame altogether. So now we have generic the SGLT2, which is time tested with all the evidence. So given a choice, I would prefer the tested ones rather than the ones without the data. But by and large, I think it is across the board. It's personal choice. Everything should work perfectly.
Thanks. Thanks. Bansi, any final closing comments? And then we can go to the next
one question which you had asked to Dada and Dr. Sinha was, that instead of using sulfonylurea-based triple drug combination, whether this combination of Remo with vildagliptin along with metformin, could it be a choice of therapy to patients who are initiated with this combination versus the sulfonylurea as a first line? As we know that combination therapy in India, we all use it, particularly the patients where A1C is more than 2 above the target. So suppose you have a patient with 8.5 and above, and you want to achieve the target of less than 6.5, we can use the early combination of the drug. And this is one of the choice which we can give to our patients, because a single drug which is given twice in a day and most cost effective also, and at the same time very easy compliance point of view. The patient feels that only one tablet is being started and he is taking twice a day, and long run definitely the A1C control, better control, everything will be there with the patient. So I strongly endorse this combination to start with the patients. But as per the guideline, the combination, they feel that you come with the only less than 8.5, you start only with metformin. If it is more than 8 or 8.5, you can think of combination combining 2 drugs, and then you can think of 3 drugs. But I go with more with Diffronjo, that starting with the early combination.
Once you're getting into Dr. Panikar's talk, master of the early combination therapy. And I think that, let me tell you, I learned this 25 years back from Dr. Panikar, that hit hard, hit early. Early combination is the way to go. I completely agree with what you're saying, that if you use a Remo, Vilda, metformin combination, we are running out late. Dr.
I was just about to say that my talk is that only.
Exactly that. That's exactly what I wanted to say. And therefore, we will listen from Dr. Panikar, but I completely agree with Bansi that Remo, Vilda and metformin is a very rational first line option. We need to hit hard, hit early. And exactly that's what we had one Dada from Calcutta, but we have another Dada from Mumbai who is now going to come in. And I'm asking our chairpersons to introduce, Dr. Panikar actually needs no introduction, but still we have to introduce him. And we will have some maybe quick interaction after his talk. But over to you, Tanuja and Hina.
Yeah, thank you, Dr. Shubhankar and Dr. Bansi, for your great talk. Next, we start the Mixed Bag Symposium. It gives me great pleasure to introduce our Dr. Panikar sir, who has been our beloved guru and a wonderful person. He is one of the senior most diabetologists from the city of Mumbai. He is also a honorary consultant with the Department of Endocrinology and Lilavati Hospital and Guru Nanak Hospital, Mumbai. He has been a professor of medicine at KJ Somaya Medical College, Mumbai. He will be talking on the early combination therapy in type 2 diabetes. Over to you, sir.
Thank you, Tanuja. Very nice seeing you. Let me just share my slides. It came, thank you, straight away. Can you see my slides?
No, sir, it's not full screen, sir.
It is not full. Does it
No,
move?
sir.
It's not full
No,
screen?
sir, no, sir. You can stop sharing and then share again.
I think I'll have to. Okay. No, this is something else. I think I have to.
Just go to the slideshow.
Yes. Slideshow.
Using a lap. Anirudh, can you guide, sir?
From beginning.
Yeah. Just
now, can you see my slide full screen?
No, no, not yet. You have not clicked it.
I have
No,
clicked
sir.
it.
No, sir. Then you have to go down on the.
No, no, wait. Slideshow, current slide. Custom slideshow.
Sir, stop sharing and share the whole screen, sir.
Now, does it show?
Stop sharing first. Vijay, stop sharing.
Okay.
Now reshare. Now reshare.
Okay. So I share screen now.
Yeah, share screen. Now go to beginning.
Just share entire screen means from beginning.
Now just click on the from the yeah, just click it.
Start slideshow from. Okay. Can you see?
1 minute. It's hung.
Does it change?
No, sir. Sir, you can unshare when you are sharing. Just click share screen and then don't click anything. Click from the entire screen button. Once you click the share.
Can you see my entire screen?
Yes, sir. Now you click from beginning.
Click from beginning.
Yes.
Can you see?
Sir, it's still not.
No, I think there is.
Mail Jimit the slides. Jimit can.
Yes, sir.
You can mail me. I can.
No, 1 minute. There is something here which we had done earlier. Custom slideshow.
Custom slideshow nahi hoega. Anirudh, please guide him.
Sir, at the end of the bar, is there a something that comes like a slide screen ka like a bigger pinch types at the end of it?
No.
What computer are you using, Vijay?
Me?
Your sharing is not correct. You're
Yeah.
sharing the PowerPoint.
You're sharing.
Share the screen.
Okay, stop sharing.
Stop sharing.
Okay. Share screen, no? Okay. Select window application.
Yeah.
Okay.
Left side left upper option.
Left side top is your Zoom screen.
Screen will be greater. Yes, sir. That only use.
Okay. And now, can you see my slides?
Sir,
can you...
Perfect. Now full screen.
Can you see full screen?
Yes,
yes, sir. Yes, sir.
Okay.
Yes, sir.
The slides are moving? Okay, perfect. At the outset, I must congratulate and thank Shashank for having organized this. In fact, we were looking forward to an actual live conference, but unfortunately, Omicron has put the spoke in the wheel and we are on a virtual platform. And it's a pleasure to have Tanuja and Hina there, and also Jimit. The topic given to me by Shashank is early combination therapy in type 2 diabetes. What you have to see is why should we aggressively manage type 2 diabetes early? See, UKPDS has shown that at the time of diagnosis, more than 50% of the patients already have complications. 80% of patients are going to die of a macrovascular disease. 60% of patients in a dialysis unit are diabetics. The end-stage kidney disease is rampant in diabetes. And now we have a new kid on the block, NASH. And it is fast becoming the leading indication for liver transplant in the United States. And India is the biggest center today. We are just seeing a tip of the iceberg. And what is the main reason? What is the cost of life? If you have a non-diabetic at 30, he's expected to live up to 75, Indian. But if he becomes diabetic, he stands to lose 14.5 years of his life. So when you are treating a type 2 diabetic who is 30-year-old, your aim is to prevent that loss of life. See that he has a nice, healthy, long life. Currently, we have 8 therapeutic classes, 6 oral and 2 injectable, and very shortly we will have a 7th oral, that is the semaglutide, which is going to be launched very shortly. This is Ralph Diffranzo's beautiful ominous octet, which shows the different pathophysiological mechanisms leading to hyperglycemia. And you have different molecules which work on different aspects of that. So it is absolutely no way in the world that one single drug is going to correct all these abnormalities. So treating type 2 diabetes with a single drug step by step is a treatment strategy which is doomed to failure. Given this finding, Ralph Diffranzo said, why not hit hard from the start? Use several drugs together to nullify many of the known defects of type 2 diabetes and preserve the beta cell function. Now the big question is how many oral anti-diabetics can be used? All the guidelines say after 3 add insulin. But what is our experience? See, till the year 2000, we had only sulfonylurea metformin. Then came pioglitazone and the glitazones, which effectively treated insulin resistance and probably preserved the beta cells. This was the paper that we published way back in 2002. Beneficial effects of triple drug combination of pioglitazone, glibenclamide, metformin in type 2 patients on insulin therapy. And what did we find? Wonderful results. Fasting postprandial coming down, HbA1c coming down, and 73% reduction in need of insulin. And in fact, almost 50% of the patients went off insulin. And I started getting a reputation in Mumbai ki insulin ban karna hai to Panekar ke paas jao. And it still continues. Then when the triple drug failed, insulin was the only option. In 2008, DPP-4 was launched in India. Can we use 4 drugs? All the guidelines say, no, you should use only 3 and go to insulin. But this is where the DPP-4 acts on this ominous octet. And if you combine it with the other earlier 3, It covers everything very nicely without any problem. So we did this study, efficacy of DPP-4 inhibitor, fourth drug in the management of type 2 diabetes. Shashank and I were there, and even Jimit is there. This is the study which we did. And almost 8,000 patients who were on DPP-4 as a fourth drug when the triple drug failed. Wonderful results. HbA1c comes down by 1.2 mean fasting, and almost 81% of the patients responded and did not need insulin. Now, when 4 drugs failed, insulin was the option. What do? Then came SGLT2 on the scene. So now can we use 5 drugs? We did it. See, this is what the current 4 drugs were targeting. And what was left was only SGLT2, which is a totally different mode of action. So it can be combined with anything. And we had again published data on this, efficacy of SGLT2 as the 5th drug. Wonderful results, weight reduction by 3 kg, fasting PP significantly down, HbA1c significantly down, and almost 87% of the patients did not need insulin. So to summarize this, it is plain and simple that there cannot be any harm in using synergistically acting drugs to achieve your targets, because they work at different sites and they can be used synergistically. It is just an application of common sense. So combination therapy should address the basic pathophysiology of type 2 diabetes and should be tailored to prevent the long-term complications of type 2 diabetes, not just glycemic control. So to address that, what should we be looking at? It should achieve good glycemic control, it should preserve the beta cells, it should treat insulin resistance, should not cause hypoglycemia, should not cause weight gain, should be renoprotective, and should have cardiovascular benefits. So these would be the criteria. All your oral or injectables will reduce the HbA1c. So basically, for achieving good glycemic control, all drugs are good. Preserve the beta cells. Progression of beta cells is what causes the progression of the disease. This is glitazones, what is highlighted in yellow. What it does is it mobilizes the toxic lipid metabolites out of the beta cell, and that is how it probably preserves the beta cell. So when you talk of preserving beta cell, we only have pioglitazone, which has shown in many studies to have durable glycemic control. Treating insulin resistance, very important. 83% of diabetics have insulin resistance. These 2 studies have shown that insulin resistance is an independent predictor of cardiovascular disease, myocardial infarction, and stroke. This is the Nurses' Health Study. I will not go into the details, but it's a long study for 20 years, over 120,000 nurses. What it told you in a jiffy was that the elevated risk for cardiovascular disease began at least 15 years before the diagnosis of diabetes. And we are harping about glycemic control. It is already there. So we have no time to waste. And these are the clinical manifestations of insulin resistance. Look at the clinical consequences. Diabetes, hypertension, atherosclerotic cardiovascular disease, heart failure, sleep apnea, PVD, stroke, PCOS, and finally NAFLD and NASH. So if you treat insulin resistance, you will be addressing all these complications which your patient is likely to have. Is there evidence that treating insulin resistance can help? Yes. Non-pharmacological treatment is diet, exercise, weight reduction. All this can reduce insulin resistance. Pharmacologically, we have metformin and pioglitazone. All the diabetes prevention trials have shown beautiful results with diet, exercise, metformin. And there are pharmacological intervention, tripod, pipoid, DREAM, ACT now. But this is the most relevant and most important, the IRIS study. What was the IRIS study? They were non-diabetic patients who had a recent TIA or ischemic stroke. They did the HOMA. If the HOMA was more than 3, they were designated insulin resistant, and they were given pioglitazone 15 to 45 milligrams. The rest were placebo. They were followed up for 5 years, almost 4,000 patients. They wanted to look at fatal, non-fatal MI and stroke. And what did they find at the end of 5 years? Recurrent stroke was reduced by 24%. Myocardial infarction reduced by 24%. New onset of diabetes reduced by 52%. But this is the first time we have a therapy which is solely directed at insulin resistance and which has shown to prevent cardiovascular and cerebrovascular events for these patients. But look at this. This is a post hoc analysis of the IRIS study, where they looked at patients who were pre-diabetic, and they were good number, 2,885. And what did they find in this subgroup, pre-diabetic? Stroke, myocardial infarction combined reduced by 40%. Stroke alone reduced by 33%. Acute coronary syndrome by 52%. New onset diabetes by 80%. These kind of results are not seen with any GLP-1 or SGLT2 or anything. This is what the IRIS study tells us, that treating insulin resistance is a very fruitful and result-oriented treatment. So when you talk of insulin resistance, you have pioglitazone, metformin. Should not cause hypoglycemia. There are only two molecules which will cause hypoglycemia, sulfonylurea and insulin. So you remove that, rest of it. So all except sulfonylurea and insulin, which tells us one thing, that in the aggressive management or any management of diabetes, hypoglycemia is the rate limiting step. If you don't have a sulfonylurea and insulin on board, then you are very comfortable. You can just treat and be happy. Should not get weight gain. There are three molecules which will cause weight gain: sulfonylurea, glitazones, and insulin. If you remove them, they're there. The weight gain with sulfonylurea is cosmetic. It is not pathological, because what it does is it removes the visceral fat and converts it into a subcutaneous fat, thereby reducing insulin resistance. So when you talk of weight gain, SGLT2 and GLP-1 reduce the weight. Metformin and DPP-4 are weight neutral. You should have renal protection. This linagliptin study has shown that it can have benefits in reducing albumin-creatinine ratio. But the main drug which has shown consistent and impressive renal results are the SGLT2 inhibitors across the board. All of them, all the studies have shown wonderful renal benefits. These are some studies with pioglitazone which have also shown significant lowering of albumin-creatinine ratio. So when you talk of renoprotective, you have SGLT2 mainly, DPP4, pio on the sidelines. Now you talk of cardiovascular benefit. This is the UKPD's metformin in overweight patients. Good results in overweight patients, metformin in the UKPD study. Which studies do we have indicating that pioglitazone anti-atherogenic properties? Proactive studies, Chicago study, Periscope study, and the IRIS study, which I just discussed. Several meta-analysis, large observational studies from UK. And this is Ralph DiFranzo's comment on pioglitazone. It is inexpensive, very effective at reducing HbA1c, no evidence of bladder cancer risk, plenty of evidence of cardiovascular benefit. So this is a short summary of the benefits of pioglitazone by reducing insulin resistance, stroke 47%, carotid intima media thickness, myocardial infarction 28%, 38%, acute coronary. These are all proactive study, quartet. But this is what is our importance also currently. The reduction of inflammation, necrosis in NASH, 50% risk reduction in hepatocellular CA. Meta-analysis of SGLT2, all the SGLT2s have shown, unlike MACE, heart failure and CV reduction is observed in both in primary, secondary. So when you talk of cardiovascular benefit, you have metformin, pio, SGLT2. GLP-1, liraglutide has shown benefit, semaglutide has shown benefit, and now you would have semaglutide coming as oral. So this is broad outline of what drugs we have and how we could use them. So what could be the pathophysiological cocktail? Like Bansi said, you could have a metformin plus pio plus gliptin plus SGLT2, 2 pills. Metformin plus gliptin plus SGLT2. This combination is already available in the US now. Metformin, pio plus SGLT2. Now this is Schmethaner has proposed an anti-diabetic combination therapy in patients presenting with established cardiovascular disease. Metformin, pioglitazone, and empagliflozin. Some of the positive and negative effects of these three individual drugs may be neutralized in combination. and some positive effects would work synergistically. So giving this combination, cardiovascular death, anticipated effect is very nice, all-cause mortality, myocardial infarction, HbA1c reduction, all beneficial. This is one of the proposed combinations. But look at our experience in polytherapy in newly diagnosed type 2 diabetes. I have this program in my clinic where it automatically calculates the estimated A1C based on the blood glucose. And it will, in a new patient who is less than 6 months, it will give you an auto prescription. So if you have this, see, it says metformin, pioglitazone, and SGLT2. Here you have, if you click here, if the female more than 60, there will be no pioglitazone. If eGFR is less than 30, there will be no metformin. If there is vaginitis or balanitis, no SGLT2. Pancreatitis, no DPP4. Cardiac problem, no pioglitazone. Edema, no pioglitazone. So now, if I press on this here, see the vaginitis, the SGLT2 has gone and it is replaced with teneligliptin. This is another example where the estimated A1C is 13.8. And here it says metformin, pioglitazone, SGLT2, DPP4, and sulfonylurea. So this has been worked, and my student, Dr. Namrata, has analyzed the data for her thesis. This data was from the period January 21 to October 21. Why January 21? Because that is the time when SGLT2 became generic. And she divided the thing into three groups, HbA1c 7 to 9, 9 to 11, and above 11. And there were 890 patients newly diagnosed in this period whose data were available, but of them, 343 who had completed 6 months of follow-up were selected. So where it was HbA1c of 7 to 9, a triple drug therapy of glitazones, metformin, and SGLT2 was given. 9 to 11, quadruple drug, pioglitazone, metformin, dapagliflozin, and teneligliptin. And above 11, quadruple plus a sulfonylurea was added. And this is the HbA1c reduction potential for different groups. Lifestyle modification across the board will reduce 1, metformin, so on and so forth. Now let us look at the first group where the HbA1c was 7 to 9. There were 74 patients. The fasting sugars came down very nicely at 3 months and at 6 months. Postprandial came down very nicely. HbA1c at 6 months was 5.46. No hypoglycemia, just a metformin, pioglitazone, and a dapagliflozin. The weight reduction, 5 kg weight reduction at the end of 6 months in this group. First group, HbA1c 7 to 9. Now we looked at the group 2, HbA1c 9 to 11, there were 81 patients where 4 drugs were given, pioglitazone, metformin, dapa, and teneligliptin. Fasting sugar came down beautifully. Postprandial also came down beautifully. HbA1c superb. Look at the weight, hardly any weight gain. There is no weight loss here, but no weight gain either. Now we come to the third group, which was the biggest group, 220. So this tells us that most of the newly diagnosed patients who come to us are coming with an HbA1c above 11. And here we have used 5 drugs, which included pioglitazone, metformin, SGLT2, teneligliptin, and glycoside. Look at the results. And here, of course, if the patient is toxic and we find that he is got ketones or anything, he should be on insulin. But this is worked very comfortable. Here, look at the fasting sugars coming down beautifully, postprandial coming down beautifully, HbA1c coming down beautifully. But look at the weight. The weight has gone up by 4 kilos. The reason being that those patients who have an HbA1c above 11 have already significantly lost weight before they came to us for treatment. And it is just that weight loss which has been regained. So that is, when you look at the group 1, there was a 4 kilo weight loss. Here there is a 4 kilo weight gain. So very wonderful results. But look at this. We had looked at the profile of tapering effects of medication in group 3. Initially, at the baseline, 220 patients were there who were put on 5 drugs. At 1 month, only 57 needed 5 drugs. And at 6 months, only 1 patient remained on 5 drugs. Most of the patients, almost 66%, needed only triple and 14% needed dual treatment. So you have 80% of the patients who will be down titrated to receive only the 3 drugs or 2 drugs. And if you see, within 1 month, almost 75% of the patients, the sulfonylurea is out. And by 6 months, hardly anybody, practically nobody has sulfonylurea. So what is the strategy? The macrovascular damage starts many years before the onset of diabetes. Microvascular complications are linked to dysglycemia. So insulin resistance and its complication and beta cell preservation has to be addressed adequately for positive long-term outcome. If insulin resistance and dysglycemia are adequately treated, you will be able to prevent or minimize all diabetic complications, including non-alcoholic fatty liver disease. Metformin and PIO, most durable, less weight gain with metformin in place. If you add an SGLT2, that's an unbeatable combination. PIO metformin gives you best result when endogenous insulin is present. That means you have to start early. You can't wait for 10 years before you start this combination. So metformin plus PIO plus SGLT2 with endogenous insulin, early use is intelligent use. An ideal algorithm would be you want to reduce peripheral resistance, you want to preserve the beta cells, that is in yellow, you have glitazones and metformin. You want no hypoglycemia, you have rest of the things here. If your sugars are not controlled with this, you could add a sulfonylurea. Among the sulfonylurea, I would prefer a modified release glycoside because that has the least chances of hypoglycemia. If you have only a postprandial hyperglycemia, you add alpha glucosidase inhibitor. If all these you're still not able to control your patient's sugar, he would need insulin. Thank you very much, ladies and gentlemen. Thank you.
Thank you so much, sir, for the wonderful presentation as always. Thank you so much, sir.
Thank you, Vijay. Just one quick question.
Yeah.
Do you think quadruple therapy is a need of the hour?
No, we have now shown you very clearly. See, there is an app available on Play Store where you can calculate the HbA1c. Calculated HbA1c, because the patient doesn't come to you with HbA1c, he comes only with a fasting and a post-lunch, if at all. So there you calculate the HbA1c. If the calculated HbA1c is 7 to 9, you give triple. If it is 9 to 11, you give quadruple. If it is more than 11, you give pentuple.
Last question.
Simple formula.
Do you believe that type 2 diabetes is reversible?
Come again?
Do you believe that type 2 diabetes is reversible?
Reversible, see, basically the beta cell apoptosis is going to continue. You do whatever you want to do. Temporarily, you may get a reversal. But if you think that reversal is going to remain lifelong, I don't buy that. Insulin resistance, Indians are insulin resistant, that is going to remain. Very significant weight reduction will reduce the insulin resistance. So temporary, you can, I know everybody will be happy, oh, he doesn't need any medicine, then he is this. But the internal pathophysiological process will still continue to be there. That you are not going to reverse.
Last question. You used to be once upon a time a big glitazone fan.
Come again. Come again. You are very soft, loudly here.
Has your glitazone practice prescription changed after the advent of SGLT2 inhibitors?
No, SGLT2 is only add-on to glitazone. Thodi glitazone. See, to my mind, Shashank, glitazone is the cornerstone in our Indian patients.
Fair enough. We have a separate talk, and this time it's not a glitazone talk. Dr. Glitazone wanted to do his triple, quadruple, and pentuple.
Yes.
Vijay, thank you so much. Vijay is my elder brother. He's going to Lilavati now to see and do clinical care. And I would request Tanuja and Hina to go to the next talk.
Thank you, Shashank. Thank you, Tanuja. Thank you, Hina. Nice seeing you. Dakshata, nice seeing you. Amit, nice seeing you. Chal, Jimit. Bye.
Dr. Tanuja.
Yeah.
Can introduce
Thank
next.
you, sir.
Or
Yeah,
Dr. Hina.
thank you, Dr. Panikar, sir, for the wonderful talk. Questions will be taken after this mixed bag symposium. Let me introduce our next speaker, Dr. Shubhankar Chaudhary. Dr. Shubhankar is one of the most senior most endocrinologists in India from Kolkata. Sir is also the professor and head of Department of Endocrinology, IG, PME and SSRM Hospital in Kolkata. Sir will be talking on the thyroid and diabetes, the emerging twin epidemic. So over to you, sir. Thank you.
Very good morning, and thanks to the organizing committee of this very successful IDSI, which has been holding programs over the last so many years, and for the kind invite to me to talk on very common issue, the association of thyroid disorders and diabetes, and it's titled Thyroid and Diabetes, the Emerging Twin Epidemic. Now, what is in store for us? Well, we all know that both thyroid disorder, especially hypothyroidism, and diabetes, and mostly we talk of type 2 diabetes, but type 1 diabetes is also there, are both chronic diseases that require lifelong follow-up and treatment. And probably thyroid disorders are more common in people, even with type 2 diabetes is of course more common in type 1 diabetes that everyone knows. And on the other hand, in those with thyroid disorder, it's also likely that type 2 diabetes is more common. And then, of course, there's the issue of diagnosis getting delayed because there could be common symptoms. For example, fatigue, weakness, not feeling up to the mark, which are common for both uncontrolled diabetes and untreated hypothyroidism. And both hypothyroidism and diabetes could affect blood pressure, lipids, and therefore affect cardiovascular health and mortality. Could also affect kidney function, non-alcoholic fatty liver disease, and maybe even cancer mortality. And some of the microvascular complications of diabetes could also be influenced by presence of thyroid disorder. So when we talk of so many associations, is it just a coincidence or do we know a causative underlying mechanism? Let's try and unravel. So we need to look both at the issue of thyroid disorder in those with diabetes and diabetes in those with non-thyroid disorder. If you look at the prevalence of diabetes in India, it's about 12% roughly. Prevalence of hypothyroidism overall is about 11%. Anti-thyroid peroxidase antibody positivity is seen in about 10% of the population. And when we talk of hypothyroidism in diabetes, there are numerous studies which give various figures from maybe 5% to 30%. But for type 1 diabetes, we know the figure is quite high. It's about 25%. Subclinical hypothyroidism is known to be increased almost twofold in those with type 2 diabetes. And thyroid autoimmunity is obviously high in type 1 diabetes and also in LADA, latent autoimmune diabetes in adults. So if you look at some studies, for example, this one from India, with the prevalence and association of hypothyroidism in our patients with type 2 diabetes, we find that the risk factors, if we compare the risk factors between those who have got diabetes and have clinical hypothyroidism and those who are euthyroid, the majority of course are euthyroid, But if you try and compare, we find there is a significant difference in the duration of diabetes. Those with hypothyroidism have longer duration of diabetes, tend more often to have hypertension, to have dyslipidemia, to have anemia, and to be obese. So if we are looking at people with type 2 diabetes, these are some of the factors that can determine which are the ones where we should be more alert to look for hypothyroidism, to ask for a test for hypothyroidism. And this is a big meta-analysis actually of prospective observational studies, not cross-sectional studies. And what it found, and this was published only recently, is, and this includes 12 prospective studies, and it found that high baseline TSH values were related to a 17% higher risk of type 2 diabetes. Similarly, low free T3 or low free T4 values were also significantly associated with the risk of type 2 diabetes. So this is the other side of the story. So if you have someone with thyroid dysfunction, then we should also be looking for development of type 2 diabetes more attentively than usual. Now, so we have looked at diabetes occurring in thyroid disorders, in those with hypothyroidism specifically, and thyroid dysfunction occurring in those with diabetes. Now, what are the risk factors for thyroid dysfunction in patients with type 2 diabetes? We have talked about duration, hypertension, dyslipidemia. We can add over here female gender, of course. Obesity, we have talked about. Those with diabetic nephropathy, those have poorly controlled glycemia, and duration we have already talked about. So these are situations where we should be especially vigilant about checking thyroid function. Now, when we talk of the association of hypothyroidism with diabetes, we are aware that there could be a confounder in obesity, because obesity is associated with increased insulin resistance, which leads to decreased deiodinase 2, D2 activity in the pituitary gland, whereby T4 to T3 conversion is decreased, and therefore there is increased TSH released from the pituitary. So some of that could be because of obesity itself giving rise to high TSH value, but that high TSH value, mind you, is not the same as primary hypothyroidism causing high TSH value. This is basically the TSH itself is high, and thereafter it will be stimulating the thyroid gland to produce more hormones rather than less hormones. So there are controversies, different studies suggesting, giving us contradictory evidence, whether progression to overt hypothyroidism from subclinical hypothyroidism is more in those with type 2 diabetes. We don't have a definite answer yet. Now, if we talk of the association of diabetes type 2 and hypothyroidism, how does it lead to thyroid dysfunction? We know that on the one hand, type 2 diabetes is associated with a reduction in TSH levels, impaired conversion of T4 to T3 in peripheral tissues, and insulin resistance and the consequent hyperinsulinemia can cause thyroid tissue proliferation because of the growth promoting effect of insulin. And so obviously this could lead to more nodule formation, increasing size of the goiter. And how does thyroid dysfunction affect diabetes, the other side of the story? Well, we shall soon see how does thyroid hormone affect glucose metabolism. But if we quickly summarize, we can see that in hypothyroidism, there is diminution in glucose-induced insulin secretion. There is reduced peripheral glucose utilization. So there is both beta cell dysfunction and insulin resistance because of hypothyroidism. Therefore, hypothyroidism could give rise to more of type 2 diabetes. But on the other hand, it also increases the risk of hypoglycemic episodes in diabetes, whether it's type 1 or type 2. Unrecognized thyroid dysfunction can therefore worsen glycemic control and also increase the cardiovascular risk in type 2 diabetes because it is also associated with dyslipidemia and hypertension. Hence, it's important to identify, unravel thyroid dysfunction in diabetes. And the diagnosis could be delayed because of symptoms being masked by presence of diabetes. So this is a summary of how thyroid hormones affect glucose homeostasis. On the GI tract, thyroid hormones increase glucose absorption. So in presence of hypothyroidism, there will be less glucose absorption. This sort of will help better glucose control or lower glucose levels. Similarly, on the liver, it increases hepatic gluconeogenesis, which increases glucose levels. But if you have hypothyroidism, the glucose levels will be lower. So these are the two factors at the GI tract and the liver where hypothyroidism could decrease glucose level in blood. However, at other sites, whether it's at the pancreatic beta cells or the peripheral skeletal muscle or adipose tissue, hypothyroidism will tend to affect insulin sensitivity, or in turn will give rise to insulin resistance, and on the beta cells will reduce insulin secretion. So this is a complicated sort of situation where you can have both a positive effect on glucose levels as well as negative effects of glucose levels by the effect of hypothyroidism. And this is once again a summary of what hypothyroidism could do to glucose metabolism and diabetes. We talked of diminished glucose absorption from the intestine, diminished hepatic glucose uptake, diminished hepatic gluconeogenesis, and so on and so forth. And it's important to remember that renal insulin clearance is also decreased. So exogenous insulin requirement could fall, or in those whose dose has not been adjusted, a risk of hypoglycemia could increase. And it's important to remember that in individuals with hypothyroidism and diabetes who have been started on treatment with thyroxine, they may require increase in insulin dose after the hypothyroidism is corrected. So this is a number so there are a number of issues to be aware of. Now, when we talk of hypothyroidism as a risk factor for new diabetes, it is this is a very well done study. This was done from Israel, looking at large numbers of individuals, which suggested that in those who are on statin, there is a much higher risk, the relative risk for developing new diabetes in those with overt hypothyroidism was at least 2. And those with subclinical hypothyroidism, the relative risk was a little under 2. However, if you are not a statin user and have got a hypothyroidism, the risk of new onset diabetes is much, much smaller. Still, the relative risk is about 1.6 for hypothyroid overt, and for subclinical, it is 1.2. Now we come to type 1 diabetes. I think it is relatively well established that type 1 diabetes is a condition of autoimmunity, and autoimmunity in pancreas also may be associated with autoimmunity elsewhere. And of the other organs, thyroid is the most commonly affected organ by autoimmunity. And so thyroid autoimmune disorders are much more common in type 1 diabetes. However, exact method or frequency of screening could not be determined, at least on the basis of this study, which was published in 2014. It has been found that in pediatric patients with type 1 diabetes who also have hypothyroidism, They tend to have higher rates of TKA at presentation, younger at onset of the disease, poorly controlled glycemia, and required higher insulin doses for control of the disease. What about thyroid dysfunction and diabetes in pregnancy? Obviously, type 1 diabetes pregnant women have higher titers of anti-TPO antibody. Women with subclinical hypothyroidism have a higher chance of developing gestational diabetes. So this is clearly an important message. In those who have subclinical hypothyroidism, we should be more vigilant in screening for gestational diabetes. Postpartum thyroid disorders are common, not only in type 1 diabetes, but also in gestational diabetes. And overt hypothyroidism in pregnancy increases the risk of diabetes in later life. So we find so many intertwining effects of diabetes and thyroid dysfunction. In terms of the impact on diabetes complications, we do find that the risk of nephropathy is increased in people with type 2 diabetes, whether it's subclinical or overt hypothyroidism. There is also some studies which suggest that retinopathy tends to be more severe in euthyroid patients, in subclinical versus euthyroid patients with diabetes. And of course, hypoglycemia as a complication is more common. We would also like to point out that the risk of cardiovascular events is also significantly increased in type 2 diabetes, even with subclinical hypothyroidism, the hazard ratio being 2.93, almost threefold higher risk. And CVD risk in hypothyroidism with diabetes, we do know is partly related to dyslipidemia, partly related to hypertension, and at least the dyslipidemia is partly reversible with thyroxine treatment. And we also are aware that TSH levels within the reference range have a linear and positive association with coronary heart disease events. So that's important in the context of those with type 2 diabetes. In terms of management, I wish to point out that HbA1c, which is sort of our bedrock for assessment of glycemic control, could be affected by hypothyroid state. As we've seen, there could be up to about 0.4 to 0.5% difference in HbA1c values in otherwise euglycemic individuals as determined by glucose tolerance test, hypothyroidism associated with higher HbA1c values, and this could lead to misclassification in certain cases, and just treatment with thyroxine, getting them in the euthyroid range, was associated with a drop in A1C level. So this is something that we need to remember. Not a very big A1C difference, but at least some difference that we have. And metformin treatment, we do know, is associated with decreased TSH values. So we should be aware of this additional effect of the TSH lowering effect of metformin in type 2 diabetes patient. Effect of so in terms of effect of antidiabetics, we need to remember metformin lowers TSH. We need to know that the older generation sulfonylureas could have a goitrogenic activity, but not so with the newer generation sulfonylureas. Thiazolidinediones could cause worsening of Graves or pitopathy. Incretin mimetics, the GLP-1 receptor analogs, have been demonstrated in thyroid parafollicular cells, C cells in animals, but not in humans. And insulin is known to modulate TRH and TSH secretion and enhance the level of T4 while reducing T3. So TSH levels should be monitored after beginning treatment with metformin. Insulin doses may need to be adjusted after starting treatment for hypothyroidism, and iatrogenic hyperthyroidism should be avoided. statins should be initiated only after correcting hypothyroidism. So in terms of guidelines as to what we should do, in type 1 diabetes, the guideline is more firm, that they should have TSH and TPO antibody at diagnosis, and probably every year or according to clinical situation. For type 2 diabetes, it is more possibly a test at baseline, and then routine annual function testing is not recommended by any guideline. However, we have our own RSSTI also suggesting, which would suggest, at least in type 2 diabetes, possibly screening at the time of diagnosis, followed at every 5 years above the age of 35. So with these, I would like to sort of come to a conclusion and suggest that thyroid disorders and diabetes quite often go together, and we need to have a pragmatic thyrovigilance in those with diabetes. Similarly, in those with thyroid disorders, we should also look for diabetes. So with this, I would like to thank once again, and I would be happy to answer any questions. Thank you.
Thank you so much, sir, for the wonderful talk. We don't seem to have any questions, so we are concluding this wonderful section now. To chair the next session, I would like to invite Senior Professor Dr. Shrikan Sapadnekar, sir. Sir has been Medical Director of Godrej Memorial Hospital, Mumbai, and sir has been also former Director of Hafkin Institute of Research. It's my pleasure to welcome you, sir. And another announcement is that Dr. Sudhakar Maskar, sir, isn't been able to join live here. So Dr. Shashank Joshi, sir, will be talking this talk. Dr. Sapadnekar, sir.
Thank you very much. First speaker, instead of Mr. Sudhakar Maskar, it is Dr. Shashank Joshi, who doesn't need any introduction. Over to Dr. Shashank Joshi.
So Dr. Sudhakar Maskar is very much with us, but unfortunately, you know, the Omicron pandemic is over prevalent, and probably he's indisposed with the same. I wish him a speedy recovery. And you know, many of us may not know him. He's an innovator par excellence. He's the Chief Technology Officer of Marico. He's a graduate from the famous UDCT, now called ICT, and then a PhD from CCMB in Hyderabad. And he has more than 50 patents, more than 100 publications. And today's topic is very relevant because oats is a standard of care, and oats is an adaptogen. And his topic is to look at oats, the active ingredient of oat, which reduces glucose, which is called as the fundamentally beta glucan, which reduces the prandial surge. You know, if you eat flakes like cornflakes, you know, your glucose goes up. It is a glucogenic substance. If you eat oats, it goes in the opposite direction. So we all know that in the prandial glucose control, whether it is a traditional breakfast like cornflakes or a traditional Indian breakfast like a paratha or idli or a dosa, which happens across India, you know, we will still see these glucose spikes. And with CGM now we can measure them. With AGP we can measure them. But if we use and make oats tasty, we can actually have a very good breakfast option, lunch option, dinner option, or a mid-meal snack option. So all that is possible. So it's very, very doable. So I'm going to talk on oats, and let's look at, we all know metabolic syndrome and cardiometabolic cluster is the key, whether it is the visceral obesity, the insulin resistance, the hypertension, the high triglycerides, the low HDL, and it's all got to do with, you know, the waist circumference and family history. So obviously metabolic syndrome in India is huge. And what India eats is what ICMR just got out a survey last year, is that 50% of India has abdominal obesity, and it has gone up from 18.8% to 53.1%. And you can see diabetes is almost 25%, and hypertension is almost 32% when you look at urban prevalence. And if you see the relevance of it in the current pandemic, it is this group which has abdominal obesity, hypertension, and diabetes, which is vulnerable and which has a risk for severe disease and death. So it's very, very important. So when you look at what is India eating, India clearly, if you see how much we eat and how much should we eat really. And if you see the latest NIN ICMR survey, if you see the Indian plate in urban India and rural India, so look at the recommendations. 40% should be cereals and millets, and then maybe 17% should be pulse and legumes. A good 10% should be milk and milk products. 5% vegetables, 5% fruits. 11% nuts and oil seeds, and others around 10%, and 12% are visible oils and fats. So this is the big problem in India. This is what is recommended for Indians. And if you see the Indian footprint, and this is just last year's survey, urban India has 51% of cereals and millets. So it's a carb preponderance. And rural India actually is much more. It's 65.2%. So because they are more agrarian, they need physical activity, they are more carbohydrate-centric compared to the urban India. And if you see the fat percentages in urban India is 13.7%, while it's 7% in rural India. So it's a very interesting graphic you can see here. This is true India. This is what India eats, and this has not this. The others include basically chips, biscuits, chocolate, sweets, and juices. So obviously, oats clearly is a very well studied, evidence-based food molecule. I call it as a evidence-based food molecule. If you really have to switch your eyes and the quality matters. Marico, both I have a conflict of interest, but we have done research work to show that the brand matters because the quality is very, very crucial and important. So what basically we have broken the grains. We are a cerealized economy, and the whole grains basically are very protective. Basically because of mechanical properties, insoluble fibers. So it's not just for bowel movement; it lowers lipids. Then endocrinologically, zinc, selenium, nicotinic acids. These are the second and the third messengers in our signaling crosstalk, molecular crosstalk. Then all micronutrients, they have some role, whether it's antioxidative, whether it's anti-inflammatory. And then, for cellular signaling, we need a lot, like the polyphenols, the redox status, the energy metabolism, and so on and so forth. So clearly we have a important thing. So what does really an oat grain have? So oat grain clearly has an endosperm, which is 50 to 65% carbohydrates, and it has 8 to 18% of proteins. We know there's a thin cellular wall. In that thin cellular wall of the oats, in the endosperm, we have beta-glucan, we have arabinoxaline, and phenolic compounds. So there is a thin cell wall in the endosperm, which has a molecular ingredient called beta-glucan, and beta-glucan lowers glucose. So as an endocrinologist and diabetologist, it's important to recognize that. Then in the bran part of the oats, there is a pericarp, there's a seed coat, there is aleuronine, subaleuronine, and endosperm. And again, in that thick wall, you have beta-glucan, we have arabinoxaline, and phenolics again. And in the germ, which is endosperm, the depleted layer, and the scutellum, you have a lot of minerals, vitamins, and phenolic compounds. So if you look at the nutrient formula or the molecular nutrient formula of oats, it has 389 calories per 100 grams, 7 to 9 grams of fat, 17 grams of proteins, 66 grams of carbs, and 10.6 grams of fiber. So this is really truly impactful. It's really a true representative of whole grain in the modern era. And if you compare it of the nutrient comparison with other grains, let us look at the barley, the wheat, the rice, because north of India has wheat, south of India has rice, and both the coast, east and west, also again have predominantly a mixture of wheat or rice. And clearly, if you see the beta-glucan content in rice is only 0.13, wheat is only 0.5 to 1, and barley is 2 to 20. But if you look at the oats, it's huge. Not only that, it has protein, it has fat in the right percentage, it has a starch, it has total dietary fiber, which is highest. The main component in oats is the ratio of 1,3,1,4 beta linkages. And the 1,3,1,4 beta linkages in the oats give a better water soluble property and a higher molecular weight compared to barley. So though barley might have little more beta-glucan, fundamentally the oats and the 1,3 and the 1,4 beta linkages in the oats give a better water soluble property, and the higher molecular weight in the oats compared to barley clearly as an advantage. Also, oats is higher in proteins, which are so important. We are a sarcopenic nation. We are a protein deficient nation. So what differentiates out of it? Beta glucan. Beta glucan is nothing but the naturally occurring soluble dietary fiber. It is really a soluble dietary fiber with molecular properties of glucose lowering, which is 1314 beta glycosylate brands. And this ratio of 13 to 14 beta linkages in the oats give rise to water soluble property and increases the viscosity. And that slows the gastric emptying. So it is like any of your, DPP-4 inhibitor or incretins. It's better than that. It is like a sleeve gastrectomy. Oats is the food equivalent of a sleeve gastrectomy. So it slows gastric emptying and delays digestion of the food matrix. So it's a very unique fingerprint here when we are talking of the beta glucan. Beta glucan is a soluble dietary fiber with 1314 beta glycosylate bands, which makes the oats more viscous, slows the gastric emptying, and delays the food matrix. The second thing which oats has is protein. It among all the cereals which we have, whether it's wheat, whether it is barley, whether it's everything, the highest protein content is in oats, 11 to 15%. And it has a very high globulin to proalanine ratio. Now, what is the importance of globulin to proalanine ratio? Fundamentally, the quality of protein matters. And remember, the higher lysine 4.2%, which is the limiting in wheat and other cereal grains, fundamentally what oats has is a balanced amino acid profile with a superior protein quality and the apparent protein digestibility. So 85% is digestible with a 80% biological value and NPU. So that's the second component of oats. And Marico has done standard innovation to make the protein satiative and tasty. So that's what really the whole philosophy of masala oats does. And that's really making the big difference, which others innovators have not been able to do, because they are the true innovators as far as the Indian conditions are concerned. And the third thing which oats has is the evanthramides. What are evanthramides? They are mainly found in the oats. They are low molecular weight, soluble polyphenols. What are polyphenols? These are substances or chemicals which are anti-proliferative, anti-itch. Skin remains very good, cytoprotective, vasodilatory, and anti-inflammatory. So we are into an endocrine diabetes meeting. How does oats impact blood glucose and glycemic index? Well, the GI of oats is important, because what is the mechanism that the glucose load and the blunting of the prandial glucose occurs? Fundamentally, the oat phenolics inhibit the alpha amylase and alpha glucosidase enzyme. And we also know that beta glucans in the oats increase viscosity and delay gastric emptying. And the proteins in the oat also delay gastric emptying. So the oat starch, whether it is the granule size, the crystal type, the amylose content, and the degree of branching, every oat is different. And therefore it needs studies. And that studies Dr. Musker and his team, and some of them I have done, clearly we have shown that it makes a difference. Also remember that the colonic fermentation makes short chain fatty acids. And these short chain fatty acids regulate the GLUT4 transfer into the cell. And the oats proteins have an insulinotropic effect like an incretin. So they increase the GIP and the GLP-1, and they are insulinotropic. So from a mechanistic standpoint, you can clearly see that oats are like an alpha amylase alpha glucosidase inhibitor. They increase viscosity, decrease gastric emptying, either through the beta glucan mechanism or through the oat protein mechanism. They have a very low GL based on the granule size, which masala oats has, crystal type, amylose content, and degree of branching. And they also alter the gut microbiome through the colonic fermentation of the short chain fatty acids. And they also have one more property, which is that they reduce the action of P13K-AKT, which again is very important for the GLUT4, which is there in the muscle for cellular metabolism. But whatever I talk mechanistically, do we have evidence on masala oats? This is data from abroad, which shows that when you use in vitro oats, clearly you can see that the beta glucan decreases, ensures that the glucose will come down. But not only that, you can see here in this study, the increased viscosity because of the delayed gastric emptying. Both this, and this is RCT, because nowadays we need RCT. So this is studying the meal viscosity of oat beta glucan on human appetite control done by Ribello et al., clearly suggesting this same. And long time back with Dr. Lewis and Dr. Musker, they had done this study. 2005, they published it on the viscosity. So this is the data which is new now, which is being presented, where we had a test group where lifestyle changes with flavored oats versus lifestyle trainers with traditional breakfast, which is like a cornflakes or something. And we did AGP. I was a part of this study, and we did 14-day AGP. Now AGP is available, and we measured in the test group versus control group. Clearly, you can see in the pre-diabetic subjects, the fasting glucose came down and the postprandial glucose came down. So this is hard evidence on Indian population in a proper, randomized controlled fashion, where we have shown masala oats, which Marico makes on the AGP pattern. And this is the glucose excursion. You can see that in the oats, savory oats, which is masala oats, clearly you can see the glycemic effect is impacted. And you can see that it also has a spillover effect. It is called as a second meal effect. So the first thing the oats do is they decrease the prandial glucose curve, but they make you less hungry for the next meal. That is called as a second meal effect. And that is so crucial in the Indian population. So that was as far as the glucose impact is concerned, appetite impact is concerned. What about impact on lipid profile and dyslipidemia? Clearly, we know that oats reduce cholesterol. There's global data to show that. In fact, excellent data published in US, Europe, and even now in India with Dr. Muskar's team. And you can see as several studies indicate that beta glucans are an active cholesterol reducing component of oats. They reduce cholesterol absorption by binding the ability of the beta glucan to bile acid. They favor exclusion of bile acid. They reduce the cholesterol and bile acid at the activation of 7-alpha hydroxylase, which upregulates the LDL receptor. So that is where it acts. And once the LDL receptor is upregulated, the transportation of LDL to hepatocyte occurs. So that is one mechanism how cholesterol is reduced. And then there is conversion of cholesterol into bile salts. So if the cholesterol is high, the beta glucan will go into the bile acid. There is exclusion of bile acids, and there is a reduction of cholesterol and bile acids with activation of the 7-alpha hydroxylase and upregulation of LDL receptors. Therefore, LDL is transported into the hepatocytes, and there is conversion of cholesterol into the bile salt. That's one mechanism that cholesterol absorption is reduced. The second thing is the production of LDL is also reduced. Why? Because in the gut microbiome, these short chain fatty acids at the colonic level, which are fermented by beta glucan on the colonic microbiota, inhibit LDL synthesis. And when they inhibit LDL synthesis, cholesterol levels come down, and that's what oats shows us. So obviously, to maintain heart health in vitro, so this is all in vitro. Okay, and this is again data done by Dr. Musker in his lab at the Marico Research Lab of masala oats, minor constituents, eventhramides. They induce nitric oxide on human cell lines. This is original data. They enhance nitric oxide on impact on health of arteries. There's a 44% enhanced release and 11% production or reduction on the production. So this is Dr. Muskar's original work, where he has shown in the human cell lines, which he has developed in the Marico Research Labs in Mumbai, that the nitric oxide impact on health for arteries and proliferation of smooth muscle cells is also reduced. Eventhramides. Now, we all know eventhramides is a very, very important component. It has an effect on blood glucose, induce DNA synthesis on the human vasculature. And clearly, we all know that eventhramides have an impact, negative impact on vascular cell proliferation and on the synthesis of nitric oxide production in the human vascular smooth muscle cells. So again, clearly very high impact. So again, we need evidence. Can oats impact the cholesterol? So this is another study done by Dr. Anup Mishra's group, who is going to give an oration today later, a prospective randomized parallel control studies, where they took usual diet and then they took oats in the morning and oats upma at lunchtime. Clearly, you can see daily consumption of 3 grams of soluble fiber from 70 grams of oats leads to a beneficial effects on lipid parameters, total cholesterol, LDL cholesterol in the Indian hypercholesteremic populations. We all know Professor Mishra's group is a lead group in nutrition from New Delhi, and he's a good friend of all of us. What about impact on weight and BMI? Clearly, we know endocrinologically, the luminal viscosity goes up with oats, the gastric emptying is blunted, the prandial glucose comes down, but also intrinsically, when the energy density and palatability is reduced, and when we chew more, because for oats you have to chew more, you feel full fast. And then there is fat storage which decreases and fat oxidation which increases. And at the colonic level, when we ferment the short chain fatty acids, again we promote satiety and reduce the hepatic glucose production and free fatty acids, improve insulin sensitivity, and overall lead to a body weight loss. So, Dr. Musker has this internal lab This is again a Medico internal lab where he has a breath analyzer for body metabolism. And we know fat burns out body and gives out acetone. So he has this acetone breath test. So we know that fatty acids are exposed to the liver. They make acetoacetate, whether it could be acetone or beta hydroxybutyrate. And you can clearly see in his lab when you gave Safala masala oats, which is SMO, poha, which is a very common thing. Today morning I had poha. I wish I had oats, and noodles, which is also very popular. You can see the graph. You can see the graph how the Safala masala oats clearly make a difference. Clearly make a difference on the acetone production. So that's something which we recognize very well. And here you can see again the fat burn index of Safala masala oats versus poha versus noodles, because these are three common foods which common man in India eats. And you can see how beneficial it is on the fat burn index, which has been documented. This is all for publications. So is there global data? Am I talking just off my hat? No. There have been small randomized control trials across the world to show, and this is a trial done by Shusher, Jessica's group, and she has shown from a group 40 grams of oat per day for 8 weeks, usual diet versus control, improves glucose, insulin resistance, weight reduction over 8 weeks. What about blood pressure? Because we have a twin epidemic of diabetes and hypertension. Well, oat fibers clearly activate the short chain fatty acids like acetate, butyrate, and propionate production in the colon. They activate the G protein receptors which are there, and they also have an impact on decreasing blood pressure through two mechanisms. One is they impact the signaling in the brain, and they reduce renin. So there's an olfactory receptor in the brain, and they reduce renin. And this is Chinese trial where they have done a randomized control trial published last year only in 2021. Zhu et al., which has shown that oat bran and the dietary fiber in the bran reduces blood pressure in a RCT form on overall the blood pressure. So the similar study has been done, and this is that study clearly showing randomized prospective control trial over 3 months, hypertensive populations with oat, and you can clearly see that when you supplement with them with oat, the blood pressure improves, the number of antihypertensive drugs come down, and the gut microbiota is modulated. So clearly what we have shown is oat is an adaptogen. We should adapt it into our day-to-day lives. We are into a stress zone. We are into a stressful zone. So we need to lower glycemic variability like dietary fiber, the proteins, the phenols, and clearly oats reduce glucose load. They reduce the glucose glycemic load, and they reduce glycemic variability as we have shown by the AGP studies in-house. They clearly reduce the total cholesterol and LDL synthesis as seen by the increased excretion and the short chain fatty acid production. They clearly have cardiovascular protection. I have not shown you the US data. We have only shown in-house data, which is what Dr. Maskar always presents. His original work on aventrinide, it's completely made in India, and it has to be tasty. They also lower weight, they lower body fat, they lower energy, they have a lot of fiber, and they improve blood pressure. So clearly oats make an impact. So it's a food solution to prevent metabolic syndrome. Obviously, the Safala oats is a proprietary. They have done their own regional research. It is tasty and it is healthy. So oats are clearly an adaptogen. Of course, it has to be integrated with lifestyle, because there is no point. Of course, you should have a healthy meal, but in that healthy meal, whether it's a breakfast meal, a lunch meal, or a dinner meal, or a mid-meal snack, it is a true adaptogen with Indian evidence base and Indian taste. But it has to be integrated with lifestyle. Slow down, keep calm, be positive, take it easy, unplug, breathe well, relax outside, meditate, and obviously have an oats meal. Thank you for a patient hearing.
Thank you very much, Dr. Shashank Joshi. There were compliments while the talk was going on the chat. Our next speaker is going to be Dr. Parag Shah from Ahmedabad. Dr. Parag Shah is a senior endocrinologist, and he will be presenting to us clinical implications of glycemic variability, a very important topic, glycemic variability, and that will be elaborated by Dr. Parag Shah from Ahmedabad.
Your dear and dear ones are healthy, and I thank my dear friend and brother, Dr. Shashank, to give this one more opportunity to share my views about one of the very interesting topic, that is about the glycemic variability, clinical implications of glycemic variability. So what I'll be discussing in next 18 or 20 minutes, what actually means the glycemic variability, what are the effects of glycemic variability on the micro and macrovascular complications. We'll just then touch upon the different anti-hyperglycemic agents and what is this impact of these agents on the glycemic variability. And one of the very important topic not commonly discussed about the diabetic specific nutrients and what is its role in overall glycemic control and reduction into the glycemic variability, because this is the pillar stone of diabetic management. But many of the times we focus more on the management parts by the pharmacological agents or investigational approach, but many times we neglect the diabetic specific nutrients. So we all know that controlling the blood sugar is of immense importance in diabetic management, and it can decrease the micro and macrovascular complications. But we all would agree that in spite of reduction into the HbA1c, many times we are not able to reduce the micro and macrovascular complications. So many of the times we have an elusive goal for many patients with the diabetes with a good A1C control, still suffering from micro and the macrovascular complications. So what is the understanding about the diabetic related complications which has come into our knowledge? The pathophysiology we have to understand why diabetic patient gets the micro and macrovascular complications. It is basically because of the two major deleterious metabolic alterations which diabetic patients have. One is because of the hyperglycemia, there is a excessive glycation, and because of the fluctuation in the blood sugars and a persistent hyperglycemia, there is a generation of the oxidative stress. And all two together, along with other metabolic abnormality like central obesity, hypertension, dyslipidemia, bad lifestyle, smoking, would aggravate the chances of macro and macrovascular complications. So because of the hyperglycemia, there are three main glycemic disorders which gets activations of these deleterious metabolic alterations. One is a fasting hyperglycemia, second is a postprandial hyperglycemia or overall HbA1c values, and which is emerging now as one of the very important but not that commonly focused about the role of glycemic variability in a diabetic related micro and macrovascular complications. So what actually does this glycemic variability mean? So we know that HbA1c was considered to be the gold standard to know the status of the glycemic control. But with the same HbA1c, you can see in this chart, the one patients might have a less fluctuation in the blood sugars with the same HbA1c. Somebody might have lots of peaks and nadirs. So A1c would be the same, but naturally we wish our patients to have a such type of the curve rather than having too much of fluctuations. So this is called the glycemic variability, and it is now emerging as one of the important factor to control to prevent the diabetic complications. So what we wish, we want our patients to have blood sugar ranging from 70 to 180, and less than 70 or more than 180 is considered to be a poorly controlled blood glucose profile. So the emerging concept of glycemic variability is easily translated by time in range, because this is the way actually we can easily ask our patients to understand what is the glycemic variability, ask our family physicians to understand that is more easily is the time in range. So what is the time in range actually? What we have decided is that less than 70 and 180 sugar is not very good for the diabetic population. So what is the percentage of time in 24 hours individual spends within this range is considered to be the time in range. So ideal range, what is there is universally accepted as a 70% of this 24 hours person or a patient should be having a HbA1c of 7%, but at the same time, their blood sugar should be between 70 to 180. So around 16 hours and 48 minutes, patient should be having this much blood sugar profile. And every 10% improvement in time in range corresponds to almost 0.5% reduction into the HbA1c. So what is the target of time in range would depend upon the older or high risk population where We don't want too much stricter criteria, like we may relax the fasting target from 70 to say 100 and post meal from 180 to 200. So we want them 50% of the time to be between 70 to 180, but otherwise uncomplicated, relatively less comorbid patients of type 1 and type 2, we want 70% of their time should be between 70 to 180 range. So with the same HbA1c of 7%, we wish all our patients should be having at the same time 100% time in range, their blood sugar profile. And you can see there is a huge difference between same HbA1c and time in range. Here 100% is in time in range. Yes, only 70% is time in range, while 25% patient is having sugar more than 180 and 5% below 70. And another more worrisome is that 20% is hypoglycemic range and 40% is in range and 40% is hyperglycemia. So this two summarizes to HbA1c of 7, which is the ideal target, but this is not the ideal way to manage the patients of type 1 or a type 2 diabetic with us. So what are the time in range implications? There is a good linear relationship between time in range and HbA1c. Means more the patient is in time in range, more would be the HbA1c, but many times the reverse may not be true. That is how the association is complex. Many times A1c is 7, but patient has lots of hypo and hyper. So that is not inversely true that HbA1c is normal. The time in range may not be in the good desirable range. So time in range is an effective metric to assess the treatment efficacy. It will give a holistic approach for a better glycemic management, and it is proven as an indistinctive metric for diabetic complications, though more research is required. So what are the adverse outcomes glycemic variability might be having in terms of the diabetic complications? Macrovascular complications. If the patient has acute coronary syndrome with lots of glycemic variability, there is a poor prognosis, there is a casual role in a type 2 diabetic patient with a more glycemic variability and a cardiovascular disease, including increased risk of the stroke, death, and the myocardial infarction. Similarly, higher the glycemic variability, more chances of neuropathy, retinopathy, and more chance of hypoglycemia, including severe hypoglycemia, hypoglycemic unawareness, and nocturnal hypoglycemia. And unfortunately, higher the glycemic variability is associated with higher mortality rates, depressive symptoms, cognitive disorders, including cancers, has been reported. So glycemic variability has a huge impact on the adverse outcomes in a type 2 diabetic patients, right from the cognitive disorders, diabetic retinopathy, nephropathy, peripheral neuropathy, hypoglycemia, mortality, cardiovascular disease. So all this, one of the important factor is the glycemic variability. Just to give an example for us, diabetic peripheral neuropathy, we have seen lots of patients whom suddenly we have started insulin, they get lots of hypo and hyper, and then diabetic neuropathy gets worsened, though their HbA1c is much better. That is not a very uncommon clinical scenario. So one of the factor is we are inducing too much of glycemic variability. So what are the adverse clinical outcomes in a glycemic variability? So short-term glycemic variability, it is a intraday or intraday glycemic variability. So just day-to-day fasting plasma glucose variability studied in around 7,600 patients had a more chance of severe hypoglycemia and all-cause mortality. If there is a more increase in the MAGE, in a 200 patients, there is increased risk of coronary artery disease severity. 2,600 hospitalized patients with CAD, higher the glycemic variability as measured by the MAGE, it is positively associated with a poor prognosis in a patient who is hospitalized with a CAD problem. 28,000 patients, higher interquartile range of the blood sugar, increased risk of mortality. So this is the short-term glycemic variability and its effect on the different parameters. What about the long-term glycemic variability, which is in our routine clinical practice? This we can do very easily. This is a visit-to-visit variability of just a fasting plasma glucose. If patient is coming to back to us every 2 or 3 months, just observe their fasting plasma glucose variability. This is the study that how actually the visit-to-visit variability of the fasting plasma glucose, what are the impact of this? This is around 53,000 patients without CVD, higher the variability in the fasting, more chance of CVD and all-cause mortality. Around 1,800 patients positively correlated with the risk of CVD, around 3,800 patients without CVD, more chance of CVD and mortality. Around 32 lakh patients without diabetes, even in them, it is independently associated with CVD, and the mortality around 220 patients with a higher visit-to-visit variability of the fasting plasma glucose positively associated with the severity of the peripheral neuropathy. Similarly, the diabetic retinopathy, diabetic kidney disease, and around 4,000, 6,000 patients with a type 1 diabetes with a more fluctuations in the visit-to-visit fasting plasma glucose, increased risk of mortality, and more frequent hospitalizations. So how actually there are some studies with the type 1 diabetics which are more vulnerable to have the lots of glycemic variability. If you do the CGM and act on the CGM, then there is a reduced glycemic variability and improved protection against the hypoglycemia. If you switch over from the conventional basal insulin to the insulin analogs like Degludec, there is a minimization of the morning glycemic variability. If you add Cana, it improves the indices of glycemic variability. DAPA improves the glycemic variability. Low carbohydrate diet results in more time in the euglycemic range and less time in hypoglycemia. So what are the impacts of the different anti-diabetic drugs on glycemic variability with a type 2 diabetics? This is acarbose compared with the placebo. Significant reduction into the intraday glycemic variability, specifically postprandial variability with acarbose compared to placebo. All DPP4 inhibitor, Sexa, when compared with acarbose, almost comparable reduction into the glycemic variability. Sita compared with the glimepiride being more prone to get hypoglycemia. Naturally, Sita would have a less glycemic variability compared to glimepiride. Vilda compared to Pio, both non-hypoglycemic agents, there is more reduction in glycemic variability, predominantly in the Vilda, but both showed reduction into the glycemic variability. Lira compared to insulin, Lira being GLP-1 receptor agonist, non-hypoglycemic agents naturally would have a less glycemic variability compared to insulin up titration with a basal or the basal plus therapy. DAPA compared with the Sexa, there is not much difference pre or the post Ramadan. Insulin, aspart, glucagon, or the Lispro when compared with the exenatide. Exenatide again being a non-hypoglycemic agent has a less chance of hypoglycemia, so less glycemic variability. Lispro combined with the glargine, almost comparable, but glargine, Ditimirs compared with the glargines, both had a reduction into the HbA1c, but no significant difference between insulin, Ditimir, and the glargine in glycemic variability. Glargine compared with the standard of care, less hypoglycemia, more significant reduction into postprandial surge because of the pre-meal blood sugar, which is low and not so commonly used in our routine clinical practice. Ideg-Lira, the combination of eglutide and the liraglutides, has a significant reduction into the glycemic variability compared to Degludec alone or the liraglutide alone. And the glargine with the lexinatides compared to glargine naturally has a less glycemic variability. So non-hypoglycemic agents, specifically AGIs for Indian settings, DPP4 inhibitors, SGLT2 inhibitor, and insulin analogs and GLP-1 receptor agonists help us to have the less glycemic variability in our type 2 diabetic management. Now, most important aspect is the diet. Diet helps in weight management, glycemic control, and the glucose insulin homeostasis that all of us know very well. But how we can decrease the glycemic variability with a nutritional intervention? If you see the patient is taking the low glycemic index food versus high glycemic index food, naturally low glycemic index food would have a less postprandial surge and will have a significantly improvement into the overall glycemia, decrease into the glycemic variability, and it can have an impact on the quality of life and preventing the complications. So what does the diabetes care says, ADS says into the management of medical nutritional therapy to the structured weight loss program is strongly recommended to reduce the glycemic variability. Studies have shown a variety of the eating patterns varying in the macronutrient compositions can be used effectively and safely for the study period of 1 to 2 years to achieve the weight loss in patient with a diabetes with obesity. This includes a structured low calorie meal plans that include even the mean replacements. So how actually the diabetic specific nutrients changes the metabolic milieu of a type 1 or a type 2 diabetic patient? The key important aspects of the diabetic specific nutrients are the slowly digested carbohydrate, which will translate into the low glycemic index, reduce PPG response, so helps to have the significant reduction into the postprandial surge. Fructose, which promotes the glucose intake in liver, so it helps into the overall hyperglycemia and reduction into the glycemic variability. MUFA, replacing the saturated fats, improves the lipid profiles, and it's a good healthy option of the fat compared to saturated fat. And if you add prebiotic or the dietary fibers, it promotes the bowel health. And we all know that one of the important aspect of overall health or in a diabetic patient have to have the good bowel health, and it improves the lipid profile also. So diabetic specific formulas support the glycemic control in two ways: by reducing the total carbohydrate intakes to 35 to 40% of the energy. And if you know, STAR studies conducted by me and Dr. Shashank Joshi, they have suggested that pan-India diabetic population consume almost 70% of their calorie through the carbohydrate. So if you have the diabetic specific formulas, we can bring it down to 35 to 40%, which is absolutely a desirable diet plan. And we have a introduction of the carbohydrates in diabetic specific nutrients with a different digestion and absorption profiles with a low GI, even with the carbohydrates. So diabetic specific formulas compared with the standard nutritional beverages, you can see here, there is a significant reduction into the post meal surge, and area under the curve also is significantly reduced. So it clearly has an advantage compared to just a nutritional beverages. So effect of low glycemic index breakfast and afternoon snacks. If you just replace the breakfast and afternoon snack with a low GI food, you can see there is a significant improvement in a 24-hour blood sugar profile, glycemic variability, specifically glycemic excursions, significantly reduced. And this is an ideal situation specifically for Indian diabetic patients, which consists of having a carbohydrate rich food, and we unfortunately having a carbohydrate which responds differently compared to Caucasian populations. So we have more surge of hyperglycemia with the same amount of carbohydrate compared to Caucasian populations. So what is the clinical data for use of diabetic specific nutrients for glycemic management? A very interesting study done in around 123 newly diagnosed untreated type 2 diabetic patients, given lifestyle intervention and alone and lifestyle intervention with partial meal replacement on glycemic variability. And what we can see, those who have just a lifestyle intervention, before and after lifestyle intervention, time in range has improved significantly from 77% of the time in range to 85% time in range. But if you add a breakfast meal replacement with a lifestyle intervention, this can be improved further to almost 90% of time in range. And remember, this is the drug naive type 2 diabetic populations. So on top of the lifestyle intervention, if you have a either replacement or a supplementation of a diabetic specific nutrients, it improves the glycemic variability significantly. So what does in this COVID time, the COVID-19 recommendations by Dr. Shashank Joshi, diabetes and obesity. So one of the important aspects when the patient gets, unfortunately, COVID is to continue the agents if the patient is not critical or start them on insulin, but stricter diet and specifically diabetic specific nutrients or medical nutrition therapy is recommended if the glycemic control is not optimal. So if I summarize the importance of the diabetic specific nutrients on not only just the glycemic variability, but lots of other clinically significant or meaningful benefits, and a number of studies have shown that DSN has a superior prandial glucose response. It reduces the HbA1c, it improves the mean blood sugars, improves glycemic variability, reduces postprandial hyperglycemia, reduces the hypoglycemic risk, it increases the GLP-1, reduced because of the fibers and the slowly digested carbohydrate. The GLP-1 response would be better than the standard food, reduces the weight, improves the lipid profile, decreases the central obesity, some reduction into blood pressure because of overall metabolic health improvement, reduction into the insulin requirements, reduction into the antihyperglycemic medication or less need of uptitration of antihyperglycemic medications, reduce healthcare cost and the resources, and it may decreases the mortality. So this was the overall benefits of a proper diabetic specific nutrients, either as a replacement or a supplement in a diabetic populations. So glycemic variability is a barrier to optimization of the diabetic control and is a factor associated with the diabetic complication. We all know that patient with a lots of hypo and hyperglycemia does not feel that well, and patient with a lots of hypoglycemia, compliance with diet and medication also goes haywire. So glycemic variability can be measured using either AGP or the CGM device. Newer anti-hyperglycemic OADs has reduced glycemic variability. GLP-1 agonist and insulin analogs also has contributed significantly to reduce the glycemic variability. But diabetic specific nutrient supplement and lifestyle intervention, sometimes neglected part of our management of diabetes, leads to significantly greater improvement in the glycemic variability than lifestyle intervention alone. DSN and lifestyle intervention could be an effective treatment to decrease the glycemic variability and its associated morbidity and the mortality. Thank you very much for your patience hearing.
Thank you very much, Dr. Parag. Now, next talk is going to be by Dr. V. Mohan. V. Mohan, as all of you know, he's a chairman of diabetology at Dr. Mohan's Diabetes Specialty Center, which is IDF Center of Excellence in Diabetic Care. So without taking further time, I will pass on to Dr. V. Mohan.
Om Sai Ram, Mohan sir. We will do your talk and then we will take a few questions and answers at the end.
Yeah. I've sent my talk, so let it be shown.
Thank you.
I would like to thank Dr. Shashank Joshi for asking me to give this talk, and also thank Abbott Nutrition for sponsoring this session. The title of my session is an update on medical nutrition therapy for diabetes, and I'll try to share with you some of our own experience and a study that we had done using medical nutrition therapy in the treatment of type 2 diabetes. We all know that lifestyle modification plays a very important role, both in the prevention of type 2 diabetes as well as in the treatment of type 2 diabetes. And when you talk of lifestyle modification, it consists of weight reduction in overweight and obese people. So if there is any supplement which can help in that, it can go a long way in preventing diabetes. But also it helps in improving the lean body mass and providing the appropriate nutritional guidance. So a therapeutic supplement given as a dietary modification or a dietary supplement can help in many ways. And it's not just for prevention of diabetes or for weight loss, but can be part of the routine diabetes management as well. Many studies have shown that these lifestyle interventions, if they help you to lose weight, can prevent or delay diabetes. This is data from the Daching study done in China, which has very elegant long-term follow-up. We also have the diabetes prevention program from the US, the Indian Diabetes Prevention Program, our own DCLIP study, which we have done, and several others which provide evidence. Now, I'm going to talk today about what is called as glycemia targeted specific nutrition. It's a new term, and I'll repeat it again: glycemia targeted specific nutrition, or GTSN. And you may ask me, what is the evidence that we have that this glycemia targeted specific nutrition actually works? Now, if you look at all the studies which have been done, this is a meta-analysis of various glycemic targeted specific nutrition formulae which have been used in people with diabetes. And it will interest you to know that there are 23 studies involving 784 patients. And these are all kinds of formulae, including oral supplements, tube feedings, type 2 diabetes studies, there are 16, and even in type 1 diabetes, stress diabetes. In all of these, it has been studied. And the study outcomes have been reported in terms of the glycemic status, lipid status, medication requirement, and nutritional status. So they're not just studying the HbA1c alone, but many other parameters. And what has been shown by these studies is that these formulae, if they are used as nutritional supplements, can help to reduce the postprandial glucose levels, and 6 studies have analyzed that. The peak glucose, that means the sharp rise of glucose which occurs after a meal, especially in India with the high carbohydrate load that we eat, can be reduced by almost 30 milligrams. And then the area under the curve, if you do like a GTT, or if you see what is the glucose levels after the meal and calculate the area under the curve, almost up to 45% of the area under the curve can be reduced by using these formulae. They've been used both in short-term as well as in long-term treatment of diabetes. There are a lot of global data on using these diabetes-specific nutrition supplements over many years, and they have shown overall a reduction of HbA1c by 0.7% and a significant reduction in the mean amplitude of glycemic excursion, which means the glycemic variability, that also has been reduced, and almost 11 kg reduction in weight over a 6-month period has also been shown when used in obese type 2 diabetic patients. Now let us look at some of the Indian evidence that we have using the diabetes-specific nutrition or the glucose therapeutic nutrition supplements that are used. And this term called as diabetic oral nutrition supplement, or DONS, will be used in this particular presentation. And this study was done at our center. It's a pilot study done in obese Indians with type 2 diabetes. Now, the rationale for this, I've already told you that by using a supplementation or a replacement, a meal replacement with a low glycemic index and a high fiber meal formula may improve diabetes control. But at that time, when we took up the study first, there were no such studies in Indian patients. And I think it's very relevant in Indian studies to have Indian studies because we consume very high carbohydrate meals. So the objective of our study, the primary objective, was to compare the effect of the diabetes-specific oral nutritional supplement, or the DONS, along with diet and physical activity counseling on the HbA1c. So HbA1c was the primary objective. The secondary objective was to look at the effect on body weight, body mass index, waist circumference, fasting plasma glucose, postprandial plasma glucose, lipid profile, quality of life, and also satiety, whether it keeps you, you're replacing a meal with this formula. Does it help in satiety and reducing hunger? Now, these are the inclusion-exclusion criteria that we used. The inclusion criteria were both males and females in the age group of 30 to 65 years were included. Those with type 2 diabetes up to 1 year from diagnosis were included. HbA1c had to be between 7 to 10%, BMI between 23 and 30, and only those on oral hypoglycemic agents were used. And of course, the standard exclusion criteria, type 1 diabetes, for those who had any renal or liver problems, peptic ulcer, taking other medicines, they were all the exclusion criteria. Now, we first got the ethics committee approval, and then it was registered in the clinical trial registry of India, and written informed consent was obtained from all the participants. Patients were selected from our center using the electronic database. We have a large number of patients, as you know, almost more than 5 lakh patients, or 500,000 diabetic patients are there in our electronic records of our center. Trained dietitians contacted the patient. We had a participants meeting where the inclusion criteria was explained to them. We had a 1-week run-in period to see whether they'd be happy with the trial. And then we, after checking the adherence, we enrolled them in the study, and the compliance to the study was tested by looking at the number of empty sachets of the supplement which were returned back to us. We also, for the first time, used continuous glucose monitoring or flash glucose monitoring, which we did using the Freestyle Libre Pro, and we used our own in-house software for the analysis. Now, we also provided dietary counseling by our dietitians, and the total calorie intake of 1,400 calories per day for a period of 90 days was given, and the general advice of the do's and don'ts of diet were provided to everyone, including the control group. Now, this is the nutrient composition of the supplement that we used, and you can see that one sachet of 52 grams provided 226 grams of energy and provided 10 grams of protein. So it's quite good in protein. There's very little saturated fat, and most of it came as monounsaturated fat. And there was no trans fats whatsoever. And sugar, as you can see, was 0. And there's quite a bit of dietary fiber as well. So it's a very healthy composition of this supplement. Now, after identifying the eligible participants, we divided them after the 1-week run-in period into the control arm, where dietary counseling, physical activity, and there also with the flash glucose monitoring. And then in the intervention arm, we provided this supplement, and the diets were made isocaloric. And we had around 80% completion rates in both the arms. As I already mentioned, we measured the fasting plasma glucose, post-run plasma glucose, HbA1c, lipids, urine exam, hemogram, liver function test, renal function tests, etc. And we analyzed the results using the usual statistical analysis. Now, here are the baseline characteristics of the two groups, the control group and the intervention group, 60 in each group. And you can see there's no significant difference in the age, in the gender, the initial weight, the baseline weight, BMI, waist circumference, systolic blood pressure, diastolic blood pressure, or duration diabetes between the two groups. So this shows that the randomization has been done properly. Now, here are the baseline characteristics as far as the biochemical characteristics are concerned. And you can see that the fasting plasma glucose, post-run plasma glucose, HbA1c, triglyceride, HDL, and total cholesterol were almost identical. There was a slightly lower LDL cholesterol in the intervention group that just happened by chance. Now, let's go straight into the results. And the green is the intervention arm, and the red is the control arm. And you can see the HbA1c in the control arm. Also, there was some reduction. Obviously, we've given them dietary counseling and everything else because there's a standard of care. So when they come to our center, we cannot allow the control group to just do badly. So they also had some reduction, but the reduction in the intervention arm was much more. And these differences were statistically significant. You can see that the overall reduction of A1C in the intervention arm was 0.95, where it was 0.48 in the control arm. And this difference was statistically significant. If you look at the change in the fasting plasma glucose, there was virtually no change in the control group, only, in fact, a 1 milligram increase in the control group, whereas there was an 18 milligram reduction in the fasting plasma glucose in the intervention arm. Now, if you look at the fasting glucose shown here and the postprandial glucose shown on the other side, you can see that both in the fasting glucose as well as in the postprandial glucose, there was a significant reduction in the glucose levels in the intervention arm, whereas there was no significant difference in the control arm, in the fasting glucose shown on the left and in the postprandial glucose shown on the right. And these differences were also significant. Now, most importantly, we looked at the glycemic variation, what I'd like to call as the MAGE, or the mean amplitude of glycemic excursion between the two groups. And you can see that in the control group, there was much more variation. You can just see how much the red is going up and down. So there was a huge difference in the glycemic excursion between the two groups. In the green, you can see that the whole trend is looking lower, and also this difference between the peak and the nadir, the highest and the lowest, is much lower in the intervention arm, showing that the glycemic variability, or the MAGE, was reduced in the intervention arm. Now let's look at the body weight, and you can see that in the control arm, not much of difference in the body weight, only a 0.1 kg difference, whereas in the intervention arm, there's a 0.6 kg reduction. So half a kg reduction by 3 months in the intervention arm. And again, if you look at the BMI, no change at all in the control group, whereas there was a reduction in the BMI in the intervention arm. And this is again shown in relation to how many sachets did they take. So some people just said we'll take 1 sachet per day. That is, we'll do the meal replacement with just 1. Others said we'll do 2. So 2 meals they wanted to replace. You can see that when there was 1 sachet used compared with 2 sachets used, when 2 sachets was used, that means the meal replacement was more. There was a more significant reduction in the weight, body weight, as well as in the BMI, much more significant when 2 sachets were used. In other words, 2 meals were replaced. Now, most importantly, coming to the satiety index, and this is measured using a standard way of measuring the visual analog scale to saying how hungry do you feel and so on. And between meals, people said that they felt very much satisfied. Almost 83% of the people said that they were in the intervention arm, said that they were satisfied with that their hunger levels had come down. That is, they did not feel hungry between the meals. This is a common question people ask. If they're just going to take this 1 supplement, will they not feel hungry after 1 hour or 2 hours? In fact, this effect seemed to be sustained, because when we looked at the effect at the end of 1 month and at the end of 2 months and 3 months, you can see that they continued to be satisfied. So it seemed to work as far as the hunger was concerned. And therefore, to conclude, ladies and gentlemen, about this study that we have done, I would like to conclude by saying that there was a significant decrease in the fasting plasma glucose and in the HbA1c in the intervention arm when this diabetes oral nutrition supplement or DONS was used. There was also a greater decrease in the postprandial glucose and a lower glycemic variability or MAGE in the intervention group. There was also a greater decrease in the body weight in the intervention group. And lastly, but not least, the intervention group said that they felt better as far as their hunger is concerned, and they actually showed improvement in their satiety levels after taking the DONS. And with that, I would like to thank you all for your patient listening. And once again, thank Dr. Shashank Joshi for including this in his very important conference. And also my thanks to Abbott Nutrition for supporting this study. Thank you very much.
Thank you, Professor Mohan. Thank you so much for your wonderful words of wisdom. There are 2 questions which are asked. Do you think that this meal replacement, like an ensure diabetes care, can it become like a drug?
Like a drug, is it?
Yeah, that's the question somebody asked.
Well, it's not exactly a drug. It is exactly what it is, and that is a nutritional supplement. So one may argue, do you really want a nutritional supplement? Can you not do it with your usual meals? Well, I'm not saying that you can't. You can, actually, if you have very good control. And if you're able to, for example, cut down the carbs, you have shown and others have shown that carbs are the main problem in India. 70% all across India is showed in the START study. So if you're able to reduce the carbs basically and therefore reduce the calories, you can get the same effect. I won't say it's only due to the nutritional supplement that we gave, but the advantage of taking a supplement is that it gives you a fixed amount of calories. In this case, it was 200 calories in the sachet. So you know you're taking only 200 calories. So if you say replace 1 meal, let's say dinner, you take only this. Very little of the refined carbs in it, and it has healthy protein in it. It has fiber in it, has slow release carbs in it. Everything is perfect, and therefore at that night, at least you don't. We tend to overeat. You can get by with this. Now, next question is, will you feel hungry? That is also not there. So strictly speaking, you can't call it as a drug, but you can use it as a drug. For example, if you want to give extra protein to somebody, or you want to give some extra calories to somebody, or if you want to use it in the night, type 1 patient wants to use it to prevent a hypoglycemia, you can use it as well. So if you want to consider it as a drug in that sense, well, it's a therapy anyway. So they call it a nutrition or a drug is I think semantics. But usually in the context of meal replacement and weight reduction and better control, or prevention of diabetes or reversal of diabetes. This will work. Remember what was used in the direct trial. Only these kind of supplements were used, and totally liquid formulae were given for 3 months, and that really helped them to achieve remission. Whereas you just told them go and eat less and all that. People don't know what to eat, and especially in Indian diet, how will you measure how much of rice you took? We did an experiment where we took different idlis from 10 different sources. When we prepared our atlas, it produces 10 different results. There's no standardization. The size of the idli itself, you cannot even standardize. You can say there's always a joke which comes on WhatsApp saying, doctor said only to take 1 dosa, so I ate this 1 dosa, and show a mile-long dosa. So how do you standardize it? How do you say, what size it is and what goes into it? What is the composition? It's not like a slice of bread or something, or like an egg where you can say this is it, So that way it is useful. So if you ask me, does every patient have to take it? Well, it's a call you'll have to take. There are some people who like it, some people don't like it. But a lot of people who love taking this, saying, I'm done with this, my dinner's over. Till I reduce 10 kilos in weight, I'm going to do this. And so they get by with it. What's the second question?
One more thing is that one more person has asked the question that does it really matter whether you have a large breakfast? Because I said it in the earlier talk, large breakfast, moderate lunch, light dinner.
I think you've always been saying it, Shashank.
You lose weight, and so they want your opinion.
Yeah, I think I agree, because you see, it's a night meal which we don't tend to digest, and then it goes straight, it gets converted into fat and then liver fat, and all that happens. See, we Indians, you have shown that several times in your talk, chronobiology talks you give so well, where you say the time of the meal is also important and what you eat is also important. And that is why if you look at our forefathers, you look at the Jain type of diet, you look at the Western type of diet, they all eat at 6 o'clock. 6 o'clock is their dinner. And after that, they probably have something very light, or they don't have it at all. So that also brings in this concept of intermittent fasting quite well, because when you eat at 6 o'clock and your next meal is even at 8 o'clock in the morning, automatically 14 hours of fasting has come in there. That's one. Whereas we eat at 10 o'clock at night, number one, the gap is reduced. Number two, you're giving a very heavy carb load in the night, which you won't be able to digest. And then you'll get into bed before the digestion also occurs. And you've taken so much of carbs that they all get converted into fat ultimately. And so that's why your liver fat goes up. And so I think our Indian habit of eating late and eating too much of dinner is very bad. And people do the opposite. They skip their breakfast and then say, I'll eat more in the evening and night. I think we should reverse it. And a heavy breakfast. So eat, breakfast like a king, and lunch like a prince, and dinner like a pauper is what you say. And I think that is very true.
Two quick questions. Dr. Shah from Surat and Dr. Ramanathan from Thoothukudi, they have asked this question. Similar question there actually.
Yeah.
One is asking that, the US multinationals promote breakfast, while lunch and dinner or brunch is the main Indian food item. I'm just summarizing the question.
Yeah.
So do you think any of these supplements which you just researched on, Dr. Mohan, can be used at lunch or dinner?
I think they preferably used at lunch and dinner only, because I think our heaviest meals are usually lunch and dinner. And so if one of those meals at least you can replace, you get some benefit. But as I showed, when you do two, you obviously get much more. Because straight away 200, 400 calories. Your two main meals are finished and you only taken 400 calories. How much breakfast are you going to eat? You may eat 500 calories, 600 calories, whatever. Even then it's only 1000 calories. So automatically your calorie restriction is going to come. So it depends for what purpose it is. And then of course, see, there is no one size fits all. That we must all realize. Our lifestyles are so different. Somebody will be working the night, doing night shift, this main meal maybe at some other time. So as far as you cannot generalize and say everybody eat like that. What we eat may not be suitable for somebody else. But these are extra things which we have. And the good thing about these are, number one, there's no sugar. Number two, they're low glycemic index. Number three, they're reducing the variability. Number four, there seems to be some effect even over 3 to 6 months. I'm not saying that lifelong you'll be able to take this. And a lot of people are looking for some kind of extra protein to get, little fiber to get. So even, see, there are lean people who want to put on weight. So I'm not saying this is only for weight reduction. This is a weight reduction if you make it a replacement. If you replace one with the other. What if they want in some extra protein? Somebody whose BMI is 18 and they're feeling very weak, then you can give it as an extra thing which doesn't contain sugar.
I remember, Dr. Mohan, we wrote a paper long time back of the tDNA.
Correct. With the Jeffrey Mechanic and all that. Remember that? Very nice. Yeah.
Supplement and replacement. These are two different.
Exactly. Exactly.
That's very, very crucial. Thank you so much, Dr. Mohan.
Thank you.
Dr. Sapadnagar, any quick comment, last word? Because we are still 40 minutes. Yes, sir.
With all this, with today's overall presentation, excursions have become important, and those whose HbA1c levels are high need to pause for a moment and consult dietitians along with the diabetologist. That's the take-home message I would like to give.
Thank you, sir. Thank you so much. Thank you, Dr. Mohan.
Thank you. Wonderful meeting. Great attendance. Keep it up. I'll join you later, a little later. Okay?
Thank you. Thank you.
Bye-bye.
Thank you. So me and Dr. Sapadnagar are continuing for our next session. The next session is Professor MMS Ahuja Oration, and it is going to be given by Professor Anup Mishra. We all know Professor Anup Mishra is a Padma Shri awardee, BC Roy awardee. He was formerly the professor and head of Department of Medicine at All India Institute of Medical Sciences. Now he is a chair of NDOC. He is one of the most published authors on planet Earth, like Dr. Mohan. He has he's now the editor-in-chief of Diabetes and Metabolic Syndrome, the Diabetes India Journal. He is going to really talk on a very contemporary area, that in COVID times, how can you use non-insulin anti-hyperglycemic agents? Which agent to use, how to use, what to use? That's really the talk we are giving, and that is the MMS Ahuja Oration. And Professor Anup Mishra, as I said, is the chair of the NDOC of the Fortis group, which is across there. He has his own algorithms. He's a huge worker in all areas of diabetes, whether it is nutrition, lifestyle, medications, and he's an evidence-based diabetologist and metabolic physician. Apart from being at the All India Institute of Medical Sciences, he also spent time in endocrine training at the world-famous University of Texas Southwestern Medical Center, where Williams' textbook of endocrinology was written, and worked very closely with Professor Abhimanyu Garg and did some very elegant work in lipodystrophies as well. But today's topic is very contemporary. He's going to do the bit on COVID. During COVID time, how does a diabetic manage without insulin? What agents are safe? What agents are not safe? He's going to make a summary. He has published extensively during the COVID times, and his journal has one of the highest impact factors. And therefore, we are all looking forward to hear your oration, Professor Anup Mishra, for you.
Good afternoon. I thank Dr. Shashank Joshi for giving me this opportunity to speak on very important topic of non-insulin anti-diabetic drugs in patients with type 2 diabetes in COVID-19. And this is especially relevant since there is a repeat surge of COVID-19 now with Omicron, and we'll be seeing a lot of patients of diabetes with COVID-19, and hence it will be crucial to decide how to treat, which way to treat, and which drugs should be used to treat these patients. Now, one thing is very clear, that coronavirus is a bad omen for patients with diabetes, and this has been shown repeatedly by a number of people in number of studies. And here is one such early study in 2021, where patients with well-controlled diabetes were compared with poorly controlled diabetes, and all these patients had COVID-19, and over 28 days, their overall percentage survival was shown here. And it is very clearly shown that the well-controlled diabetes have marked survival advantage as compared to poorly controlled, and you can see a hazard ratio of 0.14. And all the complications of COVID-19 are prevented in patients who are well controlled. So beside mortality, septic shock, ARDS, DIC, acute kidney injury, all were markedly lower in patients who are well controlled. So it is terribly important for us to control diabetes whichever way that we can. Not only diabetes, but patients who are not known to be diabetes previously. And upon hospitalization have been shown to have slightly high sugar. Now you can see the sugar values are not very high, up to 7 millimole, and you can see the conversion of millimole to milligram deciliter here. And even within this range, which is not considered to be high, higher sugars were shown to have higher 28 days mortality, and the hazard ratio of 2.30, and for in-house complication, in hospital complication, 3.99. So not only patients with diabetes who are poorly controlled, they are at risk. Patients who are not known to be diabetic and have discovered to be having slightly high sugar also are at risk. All these again tell us that we should control blood sugar of our patients very well. So how to do it? Which anti-hyperglycemic drug to treat and when? Let's go further and see. Now there are a couple of concerns here and a couple of practices that we have been doing for the past 2 years. In general, physicians continue anti-hyperglycemic drugs in mild COVID-19 when only home quarantine is required. In moderately severe COVID-19, when hospitalization required, patients are often switched to insulin by physician. Now there are a number of concerns. Which drug should be preferred in non-hospitalized patients? Should we continue some oral drugs in hospitalized patients when hemodynamic compromise and major oxygen saturation are not present? And which drug should be continued during hospitalization and after the hospital discharge? We have written a number of papers on COVID-19 and diabetes. This is one of the most quoted papers since the beginning of the epidemic, almost more than 500 citations. So we go on to discuss metformin, which is the most common drug. So let's see where metformin stands as far as COVID-19 patients are concerned. Now, in this particular slide, I have put together all the studies which are case control studies. One group, there is a comparative group, and there is a group where patients are treated with metformin. And then you can see mostly these are retrospective studies. There is one prospective study, which is Coronado study, and observational study, a countrywide UK study, which is a huge study. Number of patients were taken in consideration in this particular study. Now, these studies have been divided into 3 categories: studies that suggest neither harm nor benefit, studies that suggest possible harm, and studies that suggest possible benefit. There are a number of studies which suggest possible benefit. And you can see that most of the studies which are suggesting possible benefit, the mortality has been taken as the endpoint. Now, these have been well described and summarized in an article by Avdesh and another article where Avdesh and myself have been involved. Now, if you go back, I'll take this particular study, this one. So this is a case control study with metformin with 6,256 patients, mean age, they're all elderly patients. And overall, metformin use was not associated with significantly decreased mortality in overall sample men and women. But in women, it was shown to be associated with decreased mortality by Cox professional hazard method and propensity matching score. And you can see here that in women, how it is decreasing mortality, whichever model is being used. There are a number of reasons, and I shall discuss that in the next couple of slides, by which metformin may be acting in a favorable manner in patients with COVID-19. But in women, possibly metformin decreased TNF-alpha and activated CMPK, which can induce conformational changes in ACE2 receptor. In this slide, we have summarized all meta-analysis where metformin has been considered. And you can see from the initial times, 4 studies, 5 studies, and then 6 studies, up to 10,000 patients. And if you see the odds ratio, they are in favor of metformin. The relative risk reduction for mortality ranged from 25% to 46%. This is uniform in all meta-analysis. So it seems that metformin is favorable, and whenever possible, and to whatever extent possible, we should use metformin. Now, there are a number of mechanisms which have been proposed, by which metformin may be beneficial. Reduction of insulin resistance and body weight, reduction in immune hyperactivation by inhibition of mTOR pathway, induction of CMPK pathway. I think this is important, leading to anti-inflammatory effects, suppression of mitochondrial ROS, and effect on sodium hydrogen exchanger, interleukin 6, and TNF alpha. Now, this is better depicted in the next slide. On the left side is how the virus enters, duplicates, replicates, and then subsequently causes damage. On the right side is the mechanism of metformin, on what steps metformin acts. There are a number of steps, up to 9 steps this has been shown to act. But most important steps are inhibits virus binding to receptor, steric hindrance due to phosphorylation, effect on AMPK and mTOR pathways, and increase in endosomal pH that reduces viral replication and maturation. So having discussed metformin, let's go to DPP-4 inhibitors, another very popular drugs and very commonly used as far as India is concerned. Now, there is a good premise for using DPP-4 inhibitors in COVID-19 because DPP-4 receptor is the entry receptor for MERS-CoV infection. And we have known that previously. And both ACE2 and DPP-4 could be involved with receptor binding domain of SARS-CoV-2 as shown in a crystallographic study. Now here again, we summarize all studies where one control group has been present and except one study where case series has been shown here. Again, we categorize studies according to those who suggest no harm or benefit, studies that suggested harm, and studies that suggested possible benefit. This is a huge study, which I've shown earlier, countrywide study in UK. This is the prospective Coronado study, and this study I'm going to discuss in the next slide. As you can see, as compared to the slide of metformin, there are more studies which show no results, but a few studies which show either lower rate of intubation, lower severe COVID-19, significant reduction in death, and higher chances of being discharged, etc. Now, I'm going to describe this particular study. This is one of the early studies which were published in Diabetes Care, where total of 338 patients divided into standard of care versus sitagliptin were taken, and 28 days mortality was shown. And you can see the graph diverging, clearly showing that use of sitagliptin led to decrease in the mortality, while the mean glycemia during hospitalization in standard of care versus sitagliptin was same. So this was significant, and the hazard ratio was 0.44, meaning thereby 56% reduction as far as mortality is concerned. So this was a sort of a study which gave early indication that sitagliptin may be a drug which may be showing favorable effects in COVID-19, and then subsequently other studies either did not show or did show. And again, we present to you meta-analysis, 3 meta-analysis, 7 of first was 7 studies, then 9 studies, then 10 studies, increasing number of patients. Now here, there's a vast difference between what I showed you as far as metformin is concerned. 2 meta-analysis showed no mortality benefit, and 1 meta-analysis showed 25% reduction, relative risk of reduction in mortality. So things are not so clear as far as the DPP-4 inhibitors are concerned as compared to metformin. Again, there are a number of mechanisms which have been proposed, including reduction of inflammasome and C-reactive protein, effect on CD26, inhibition of lung fibroblast, and action on soluble DPP-4 CD26 levels, which may keep SARS-CoV away from target cell entry. Let's go further and look at one of the most controversial drugs as far as COVID-19 is concerned, and that is SGLT2 inhibitors. There is ifs and buts as far as SGLT2 inhibitor use in COVID-19 is concerned. In general, SGLT2 inhibitors are avoided, stopped in patients with COVID-19 because they may cause hypotension and euglycemic ketoacidosis. However, some actions of SGLT2 inhibitors may be important, and they may help benefit COVID-19 patients recover. First is inhibition of glycolysis, which is a pathway that can be used by respiratory pathogens, reduction in oxidative stress and inflammation, and improve endothelial functions and oxygen carrying capacity. And in fact, a nationwide observational study from UK showed significant decrease in death by 18% in SGLT2 inhibitor users compared to non-users. But then subsequently a study was planned, which was a randomized, double-blind, placebo-controlled trial, a gold standard trial in patients with COVID-19 who have enough cardiometabolic risk factors. And the primary outcome for prevention was composite of time to new worsened respiratory, cardiovascular, or kidney organ dysfunction during hospitalization or death from any cause at any time during 30 days treatment period. And you can see a wide variety of patients were included in this particular trial. Almost 50% had diabetes and 51% were non-diabetic. Many patients had heart failure, hypertension, atherosclerotic cardiovascular disease, chronic disease, kidney disease, etc. So patients had cardiovascular risk factors. Also, more than 60 years, almost half the patients were more than 60 years, also obese. And these patients were being treated with number of drugs, but most commonly insulin. Let's have a look at the results. If you see dapagliflozin versus placebo, 625 in each arm, and here is the hazard ratio. A reduction was seen in the primary composite outcome and individually in respiratory decompensation, cardiovascular, kidney dysfunction, and death from any cause. And you can see here. This is also shown here. And cumulative incidence was also shown, dapagliflozin versus placebo. Although reduction was seen in almost each and every individual components and the primary outcome, but the results were not significantly different. And interestingly, not much of side effects were seen in patients with dapagliflozin, and hardly any patient had ketoacidosis. So, coming back to dapagliflozin once again, the what we thought that dapagliflozin may actually harm some patient because it may lower blood pressure, may cause euglycemic ketoacidosis, it did not cause. And if at all, there's some improvement in some of the endpoints. Now going to GLP-1 receptor analogs and pioglitazone, and we have a recent study, which is a very big study. Total 229,809 patients from 56 large healthcare organizations. Records were evaluated for GLP-1 receptor analog, pioglitazone, and DPP-4 inhibitor, and matched for age, sex, race, ethnicity, body mass index, and significant comorbidity. So a multinational retrospective cohort study. And you can see, if we look at the GLP-1 receptor analog, DPP-4, pioglitazone, significant reduction in hospital admissions. And as far as respiratory complications are concerned, again, GLP-1 receptor decreased along with some effect by DPP-4 inhibitors. And going further, mortality, GLP-1 reduced mortality. So a huge study. And for the first time, we are seeing some effect of GLP-1 receptor analogs, good effects on admissions and mortality. So if we summarize this particular study, use of GLP-1 receptor agonist and or pioglitazone was associated with significant reduction in hospital admission. So pioglitazone also was found to be good. And use of GLP-1 receptor agonists associated with reduction in respiratory complication and incidence of mortality. And DPP-4 inhibitors. Now we're coming back to DPP-4 inhibitors after that inconclusive data that we have shown earlier, was associated with reduction in respiratory complication and continued use of DPP-4 inhibitor after hospitalization during and after was associated with decrease in mortality. And we have another study, rather a meta-analysis of 19,000 patients from 9 studies, which also echo the same data that suggests that pre-admission use of GLP-1 receptor analog was associated with reduction in mortality rate from COVID-19 in patients with diabetes. And so this was odds ratio of 0.53. And this is shown very well, various studies, and shift to the left as far as the odds ratio is concerned, favoring GLP-1 receptor agonist. There have been some other trials, but they are not good enough. Data regarding sulfonylureas and glanides remain inconclusive, although one study showed lower death rates in sulfonylurea users than non-users, and randomized controlled trials are in progress with following drugs: metformin, linagliptin, sitagliptin, and semaglutide, and we shall be probably wiser after a couple of months, and hopefully they behave the same as far as the Omicron epidemic is concerned. So I summarize my presentation. Most studies are retrospective, as you have seen, and propensity score matched. And here the problem is that all confounders may not be matched properly. So we are looking at the data which are not very perfect, a little imperfect, and certainly we need clear data such as that shown with dapagliflozin, a randomized double-blind controlled trial, which are difficult to perform in the current setting. And very few robust RCTs and prospective studies available. Moreover, data regarding in-hospital use of drugs and morbidity mortality are not known. But some general conclusions can be drawn, but these need further data, that metformin should be beneficial and should be continued until and unless patient develop hemodynamic compromise, not able to tolerate metformin, and is quite sick. And GLP-1 analogs benefit we are very well conversant with, but if they are being used, they should be used because they have some effect on the admissions, respiratory complications, as well as mortality. As far as SGLT2 inhibitors are concerned, they do not show any harm. No increased ketose doses in patients with COVID-19 and could be continued in selected patients. And DPP4 inhibitors should be preferably continued during hospitalization if possible, and then after discharge as well. So thank you, Shashank, and the organizing committee for giving me this opportunity, and I'll be happy to take any questions from the audience. Thank you.
Thank you, Professor Mishra. This was a very contemporary topic. It was a need of the hour. We all know that managing diabetes during COVID times has been a huge issue, and it's particularly relevant. A lot of us use a lot of insulin, but there are separate dedicated symposiums for the same. But Professor Mishra in his oration has taken us through the full overview of all the non-insulin antihyperglycemic agents. And that was a very nice presentation. I'm just going to ask a simple comment from Dr. Abhishek Bhattacharya from UK, from Leicester. You are seeing a lot of Omicron, as well as you saw the Delta, you saw the Alpha, you saw the original Wuhan strain in UK. What has been your experience with oral agents in UK? What is the British experience? And then maybe I'm asking Professor L. Srinivasmurthy to share his Bangalore experience with COVID and oral anti-diabetic agents. And then we'll go to Professor Bhattacharya's presentation.
Thank you for the question, sir. Sir, so what I noticed, like from the presentation also, Doctor mentioned that the SGLT2s have been quite beneficial, and we have been using that. The other thing is, like you rightly mentioned, the mainstay treatment during the hospitalization has been insulin. And especially with the use of steroids during the hospitalization stay, we have seen a lot of erratic blood sugar levels. And I think close monitoring is required post the hospitalization period as well. And I think that is the need of the hour, not only just managing it within the hospitalization period, but once they are out of it, I think the titration of the medicines is very important at that time.
Thank you. Dr. Srinivasmurthy, your comments, and then you can start the next session.
Sir, your voice is not coming.
Mute.
Sir, is audible now?
Yes, sir. Yes, sir.
Yeah. I think in mild to moderate cases, I've been using the OHS continued. I'm not changing anything except in SGLT2. I think in whenever the patient gets shifted to ICUs, only we switch over to the insulins. Otherwise, by and large, the OHS in mild moderate cases has been continued.
Are the questions over?
Yes, sir.
So very well kept to time. I thank the organizers for this excellent session. There have been, based on evidence-based medicine, quite substantial ones, both the sessions, and thank you very much for that.
Thank you, sir. Thank you so much, Professor Sapatnekar. And I would now request Professor L. Srinivasmurthy to introduce Dr. Abhishek and go and with the next session.
Yeah, we are moving on to the next session now with Dr. Abhishek Bhattacharya, who is joining live from UK. And yesterday, Dr. Partha was appreciating you, Abhishek, about your work doing in the economics relationship with the IPOs in type 1. I think we're very eager to listen to you regarding the elephant in the room and the heart failure and diabetes, the new phenotype. Please proceed, Abhishek. We're eager to listen to you.
Can everyone see the screen?
Yes, yes, perfect.
First of all, I would like to thank Dr. Shashank Joshi, sir, my guru, my mentor, because of whom I'm here, and my family for the continuous support. It's a cold winter morning from UK, so hello to everyone. Today I'm going to be speaking on diabetes and heart failure, and going to be mainly focusing on the new phenotypes, which is basically the elephant in the room. My talk is going to be divided in 4 or 5 platforms. So the first thing that we are going to talk about is heart failure and diabetes, the basics. We then move on to the diagnosis and mainly focus on how the new phenotypes have emerged, and especially from the Asia where our population is based, and then how accumulating all this data, all of us can make a very patient-centric precision approach based on these phenotypes to tailor meet our patients' needs. Now, I really like this line, heart failure, the frequent, forgotten, and often fatal complication of diabetes. And during the course of the presentation, I'll show you how it is forgotten. You can see that it's highly prevalent in patients with diabetes, when occurs with more than 1 in 5 patients aged over 64 years, and patients with both diabetes and heart failure, we have seen to have a very poor prognosis with a median survival of around 4 years. When we collect the data and we see that the 5 variables of A1C, LDL, blood pressure, albumin, and smoking are within the target range, we still saw that the hospitalization for heart failure was almost 1.7 times more compared to acute MI and stroke, which are usually our MACE outcomes in all the CV studies that we do. When you look at the global burden of heart failure, there's more than 60 million patients worldwide, with heart failure being #1 reason for hospitalization in patients over 65 years of age. If we concentrate on this curve, we can see that the presence of heart failure in patients with diabetes is associated with an increased risk of death. However, conversely, the presence of diabetes in both heart failure with reduced ejection fraction and preserved ejection fraction increase the risk of cardiovascular events and death. When we look at the graph for the all-cause mortality, we can see how the rates are much higher in patients with diabetes and heart failure with reduced ejection fraction. I feel this is a very important slide, and we should all concentrate on this, because we all of us know that heart failure itself is an independent risk factor for type 2 diabetes, and type 2 diabetes is also an independent risk factor for heart failure. And when we combine the two, there's a 60 to 80% increased risk of overall death and cardiovascular death. This was an eye-opener slide. So if you look at it, the heart failure is actually the second most commonest initial CV presentation in patients with type 2 DM. If you look at the percentages, you can see that the heart failure rates are 14.1%, which is much more than non-fatal MI and the stroke outcomes. And these are usually the MACE outcomes that we are looking at. I think from going forward, maybe our studies should be altered a bit and concentrate more on heart failure as well, because that can be picked up much earlier. When you look at the etiology of diabetes causing heart failure, diabetes patients are always at the risk of more atherosclerotic events like MIs, which will result in a heart failure with a reduced ejection fraction kind of a picture. However, they also are at a risk of heart failure due to direct inflammatory microvascular effects on the myocardium. So you can see that heart failure, that diabetes is affecting heart failure both in a reduced ejection fraction manner as well as a preserved ejection fraction manner. When we go to diagnosis, it's a nice, neat slide on how heart failure is classified. The first, it's based on the ejection fraction, with less than 40% of ejection fraction being classified as heart failure with reduced ejection fraction, 40 to 49 being called as mid-range ejection fraction, and more than 50% will be heart failure with preserved ejection fraction. If we classify them based on the timing course, if there are sudden onset symptoms and worsening symptoms, we call it an acute presentation of heart failure. Whereas if the symptoms have been more than for 3 months, we are calling it as a chronic heart failure. If you're basing on the severity of symptoms, there is the class 1, class 2, class 3, and class 4. And most of them are based on how much physical activity the patient has been undertaken. Now, the first thing when we see the patient, good old history taking. Simple histories, history of coronary artery disease, history of arterial hypertension, is the patient been using diuretics, patient is having orthopnea or PND, and during the physical examination, having any ankle edema, rails, heart murmur, or displaced apex beat. If we feel if there are any one of them present, I think the next step would be to proceed with the NT-proBNP. In centers where it's not routinely done, we can directly proceed to echo. And then once heart failure is confirmed, we can start determining what caused it and then go on to the appropriate therapy measures. So the few terminologies which we will be using quite frequently during this talk. So like I mentioned previously, heart failure with reduced ejection fraction. When I talk more about it, it's basically a loss of the systolic function, and it accounts for half the cases. And most of the clinical trials, this is the cohort group that is mainly included. All our current therapy protocols are also based on most of the trials based on these patients. When you talk about the heart failure with preserved ejection fraction, it's more of the heart chambers being stiffened and thickened, and there's failure of normal relaxation and filling. It's less understood. There's more research going into it, and we don't have any proven treatment and current management. It's more of diuretics and treatment of the comorbidities. And then we have the mid-range with 40 to 49, and we are learning much more about it. And like I mentioned before, based on the type of onset, we have the acute heart failure, whereas there's rapid deterioration of the patient. Most of them have a pre-existing diagnosis of heart failure, and they usually require hospitalization, and outcomes may be worse. We have the patients with the chronic heart failure. It could be right ventricular failure or the LV failure, and treated accordingly. Now the main crux of the topic, the new ESC guidelines, and they came out with some consensus talk. It's very important that not only we are treating the patients and up-titrating the dose of the usual medications, it's also important to understand what phenotype the patient is under and treating the patient according to that. And as per the phenotype, we can target the doses and the patient gets benefit. So majority of my talk is going to be based on this circle. I think this circle should be part of all our clinicians' workup when we are seeing our patients with heart failure and diabetes. So the 4 parameters which we are going to be concentrating on is blood pressure, whether it's low blood pressure, whether it's high blood pressure, or whether it's normal. We're going to be concentrating on the heart rate as well, whether the patient is having kidney disease, and whether the patient is having heart failure or not heart failure. In between, you can see that atrial fibrillation or non-atrial fibrillation. And in between, you can see the usual medications that we have been using, the SGLT2 inhibitors, the beta blockers, the ACE inhibitors or the ARBs or the ARNIs, the MRAs, and the diuretics. So I'll be going through a few scenarios in which we are selecting certain phenotypes of the patient and how the standard of care is changing, or if any additional treatments can be attached. So in this slide, we can see this is a patient having heart rate 60 to 70 beats per minute, does not have atrial fibrillation, and kidney functions, the eGFR is lasting more than 60. In this scenario, the standard of the care is usual. We go on with the SGLT2s, the beta blockers, the ACE inhibitors, the MRAs, and diuretics. In this scenario, at this moment, we are not requiring any additional therapy. However, if the heart rate is more than 70 beats per minute, the patient doesn't have AF, and the kidney functions remain more than 60, if these standard of care medications are not working, The next thing we can go is to ivabradine, which is a HCN channel blocker. And this is how the wheel comes into the picture. The same way, if we reduce the patient's heart rate and the patient's heart rate is less than 60 beats per minute, with the same being non-atrial fibrillation and CKD more than 60, we can see how the additional therapy changes. So according to the ESC and HFA consensus guidelines, they mention instead of going for ivabradine, we go for vericiguat, which is a soluble guanine cyclase stimulator. It's an oral pill. And this is the beauty of knowing the phenotype and treating the patient accordingly. Now going to a different sort of cohort where we have the heart rate of the patient 60 to 70 beats per minute, but the blood pressure is on the lower side. Again, a patient with having good kidney functions and no atrial fibrillations. You can see that the consensus says that in this patient, we should be keeping caution with regards to beta blocker, ACE inhibitors, and diuretics. And I think the change in here is mainly concentrating on the blood pressure. Moving on to the next one. This patient, another, again, having heart rate 60 to 70 beats per minute, but you're having high blood pressure of 140 more per 90. Again, kidney functions preserved, no atrial fibrillation. The consensus says that we can go for vericiguat and hydralazine or isosorbide dinitrate if our standard of care managements are not working. Going on to another one. Again, you can see in this slide, this cohort of patient is having a low heart rate, a low blood pressure, and the consensus tells us that we need to be cautious about the use of our beta blockers and ACE inhibitors. But if you look at the pattern, the SGLT2s are still at the top, and they're not being affected much with the different phenotypes. Again, with this patient, we can see the additional of anticoagulants as an additional therapy because the patient has atrial fibrillation. Another patient, a high heart rate, but a low blood pressure, not having atrial fibrillation, and eGFR more 60, you can see an additional therapy of ivabradine could be introduced again. And again, because the blood pressure being on the lower side, we need to be cautious about the beta blocker and the ACE inhibitors. In this patient, a patient with a high heart rate, a high blood pressure, non-atrial fibrillation, and eGFR more than 60, we can see that apart from the standard of care, we can go ahead with ivabradine, vericiguat, or the hydralazine. So all of the three additional therapies can be used in such kind of a patient. Like I was mentioning with all the previous slides, that the SGLT2 inhibitors do not affect the heart rate nor the BP and may be started at any encounter with patients with heart failure. And I think the SGLT2s have risen up the ranks very gradually. Now, if we focus on the newer phenotype classification from Asia, which is a population, it's very interesting to know that heart failure, including HFpEF, can be affecting a younger cohort. And there are gaps in treatment that genuinely need to be urgent. There's also this new phenotype that has been identified, which is a unique lean diabetic heart failure phenotype. And I think there's a lot of studies that can be done into it, especially with the role of visceral adiposity and inflammation. The ESC Congress Asian heart failure cohort shows the different 5 phenotypes. Young, the ischemic having the heart failure with reduced ejection fraction, the elderly having the heart failure with preserved ejection fraction, the metabolic patients with having the heart failure with preserved ejection fraction, and then the lean diabetic who are having the worst outcomes in this group. If you can look at this slide, it shows the importance of visceral adiposity. Among the 286 patients with additional bioelectrical impedance data, each subject showed associated with 0.44 unit increase in percentage of trunk fat, adjusting for BMI, sex, and age. And that's why the role of visceral adiposity is very important and more studies are warranted. If we look at the lean diabetic model of heart failure, we can see how the PKC alpha genes, they can be causing a part of the inflammation and causing the diastolic dysfunction, resulting into a HFpEF kind of a scenario. If we look at the comorbidity clusters in the Asian heart failure group, we can see there's a good going cluster in India with the young cohort. They're having fewer comorbidities, more often with a HFrEF sort of a picture. They are having the best outcomes and the best effect of the medication. However, there's also a big cluster in India with the ischemic heart failure cohort. And these are mainly consisting of the male patients with coronary artery disease and ischemic etiology of heart failure. More often, it's a HFrEF sort of a scenario, and they are having actually the second worst outcomes. So we need to be aware of those patients. Now, at the end of the day, accumulating all the data, when the patient is sitting in front of us, this is what is all about. Patient-centric precision approach based on phenotype. Going through a few lines, so all standard treatments for heart failure likely to be effective in patients with diabetes. Metformin is safe to use in heart failure. Sulfonylurea is uncertain. Best is to probably avoid TZDs and saxagliptin in patients with high risk of heart failure. GLP agonists are likely no harm in heart failure. The SGLT2 inhibitors in patients with type 2 diabetes, with or without CVD, can be used in patients with or without history of heart failure, in patients who are controlled for HbA1c, as well as in patients on loop diuretics. Just have a word of caution. Again, coming back to that circle from the ESC consensus guidelines, the core therapies, ACE inhibitors, the ARBs, ARNIs, beta blockers, MRA, and the SG2 inhibitors. The core treatments should be used in all patients. They have a reduction in hospitalization, mortalities, everything, except the SGLT2 inhibitors. All core therapies may affect the blood pressure, heart rate, potassium level, which may require a dose change. And I think this is where introducing that phenotype chart in our day-to-day workup may come in very handful. A patient profile-based approach will help tailor therapeutic strategies for heart failure. Now, if we look at this chart, it's basically pretty much the different phenotypes that we may encounter in our daily lives. Patient with low blood pressure and high rate, low blood pressure and low heart rate, and the different permutation combinations with CKD coming in, as well as atrial fibrillation, as well as a pre-discharge patient. If we look at this chart, I think this is a very important chart, and it's very similar, just accumulating the data what we saw on the ESC consensus guidelines, that patients with low blood pressure and increased heart rate, the drugs can be given, the SGLT2 inhibitors, the MRA, but the drugs that may need to be down titrated are the beta blockers or the ACE inhibitors and the diuretics because of the low blood pressure. If the patients are having atrial fibrillation and normal blood pressure, all the core therapies are fine, along with the addition of the anticoagulant or digoxin that may be added. Patients are having low blood pressures and low heart rate. The additional drug that can be used is Varicogoac. And with the patient with normal blood pressure and increased heart rate, ivabradine can be added to the core therapy. Patient with atrial fibrillation and low blood pressure, again, have a caution for blood pressure and diuretic. The only addition there is of the anticoagulation. With pre-discharge patients, the beta blockers can be done in residual congestion, and the ARNIs with the systolic blood pressures of less than 100 have a bit of caution. Omecamtiv mecarbil can be used in selective patients, but more studies are warranted in that. Now, patient-centric tailoring of heart failure treatment, the personalized approach, I think it's pretty much summarizing of what I've been mentioning in the talk so far. The few additional things in this chart is with lung disease, asthma is a relative contraindication with beta blockers. However, they can be given in COPDs. And what is the take-home message then at the end? So heart failure is an early complication of type 2 diabetes and results in significant morbidity and mortality in the diabetic population. We have seen that the combination of two pose a 60 to 80% increase in that risk. There's a high prevalence of undiagnosed heart failure in patients with type 2 DM. We have noted that heart failure was the second most common earliest presentation in diabetes, and that has not been looked after much. The choice of anti-diabetic drugs should take into account the impact of heart failure. And the most importantly, heart failure phenotyping is the key in patient-centric precision approach in heart failure with diabetes. I would like to end my talk here. Thank you to everyone. Once again, I would like to thank Dr. Shashank Joshi sir for giving me a platform to speak. And we are all living in the COVID world, so stay safe, follow COVID appropriate behavior. I think this line is very important for all of us, whether we are in UK or whether we are in India or any other part of the world. So everyone stay safe. Thank you.
Thank you so much, Abhishek. It was a wonderful phenotypic experience. Some comments from Jimit and Srinivas.
Yes, sir. As usual, I think we were expecting Abhishek to excel in his presentation, and he proved it to be. One question I had, Abhishek, about the people with suspected heart failure or the preserved ejection fraction. How do you tackle in clinical practice, and how do you diagnose? And do you think a blanket treatment of SGLT2 is a must now for all diabetics looking at these data?
Yes, Professor. I think, like I mentioned, the studies into heart failure with preserved ejection fraction has been quite limited. And of all the three, preserved ejection fraction is the mystery thing going on right now. Currently, no approved therapy looking towards it. It's more of symptomatic treatment with the diuretics and tackling the comorbidities. But I think as we go along, I think SGLT2 inhibitors are playing an extremely important role, and I think we can proceed with them.
Jimmy?
Yes, sir. Excellent talk, Dr. Abhishek. We just wanted to know that you were discussing heart failure also, and as a dapagliflozin molecule, and we're facing COVID-19 pandemic there also. So have you seen patients putting on dapagliflozin with COVID-19 also, where either on heart failure or either previously taking their 19 trials we have seen recently? You continue SGLT2 inhibitors, specifically DAPA, those patient heart failure and admitted with COVID or any other comorbidity, inpatient.
Jimmy sir, what happens here in UK because of the NHS structure, how it is, many a times we have setups like ambulatory heart failure clinics and acute heart failure clinics, as well as heart failure nurses which follow up after the patient is discharged. And many a times the heart failure nurses are the ones who take up the role of actually initiating the SGLT2 inhibitors once the patient is discharged, rather than acutely starting them during the admission. So the heart failure nurses are playing a very important role in the whole of NHS setup. Also, a very important thing which is there in the NHS, did a few audits on the ambulatory heart failure clinic, where because of that intervention, we have prevented a lot of patients from bouncing back, because we see many of the patients, the doses are not titrated as quickly enough or as appropriately enough. However, if they can be seen in those heart failure clinics early on, we can actually prevent rehospitalizations, and subsequently more mortality rates can be lowered as well.
Any other questions?
I think no more questions, sir. Shashank sir?
Yes, we can take a short break and we can join back the session on time. Thank you.
Right, sir.
Thank you so much.
Thank you.
Thank you. Thank you.